So we are doing Respiratory Emergencies, Chapter 13 to start.
Yes.
Okay, and I should be able to share. Yep.
I just have to make sure I'm recording this.
Okay.
Okay, it's recording.
Okay. All right, y'all. Respiratory emergencies. We talked about this a good deal last time with airway management, so it's going to be a lot of similar stuff, even some of the same stuff, so it'll be a good review. So these are the objectives here. Again, we're going to go over the physiology of breathing. We've done that before. Identify the primary muscle of ventilation. We've covered that before. List some normal respiratory rates, so like what to look like for normal and maybe what's abnormal in patients, and then identify some common causes of airway obstruction. So again, a lot of the stuff that we talked about in our airway management section, some of the scenarios and issues we were encountering during that section. And let's see, we've got 13.2 here is identify the primary muscle of ventilation. Who can remind us what is the primary muscle that helps us breathe?
The diaphragm?
Yes, the diaphragm, good. And what type of injury can paralyze the diaphragm?
A cracked rib?
Cracked rib, not, it could cause pain to breathe, but remember there, what was that?
Brainstem.
Brainstem, sure, brainstem, or even if you're talking bone injuries, what sort of like spinal injury could paralyze your diaphragm?
Cervical spine.
Yeah, cervical spine, right? Good. So we talked about that in depth a while ago. If you have a C-spine injury, you can cut the nerve that goes down to your diaphragm. It goes down on the side of your neck. It's the phrenic nerve. And if you damage your cervical spine, you can cut that phrenic nerve and that will paralyze your diaphragm. There'll be no nerve to help it anymore. So that is a type of respiratory emergency. All right. We're also going to talk about these very common respiratory emergencies: asthma, COPD. Hyperventilation syndrome is basically a panic attack. Pulmonary embolism, pneumothorax. These are all bread and butter respiratory issues. We'll talk about assessments. Again, more review. We can't get enough assessments. And we'll talk about some signs of respiratory distress, what abnormal breathing looks like, and how to assess someone's lung sounds. So just trying to get a sense of how do we assess someone's breathing and what are some common things we'll see wrong with someone's breathing. That's the broad overview of today. All right, some terms to review on your own. We're learning a language here in medicine, so I encourage you to go back and take a look at anything or stop me if you need a term defined. All right, so of course, OEC technicians may encounter a patient with abnormal breathing. Problems can range from, just listing out some things: asthma, foreign bodies, pulmonary embolism. And then also you can have things that don't have anything to do with the lungs that will manifest at shortness of breath. So something like a heart attack makes your body feel like you need more air because you're not getting enough oxygen through your blood, but it's more of a blood and heart issue. It's not really a lung issue. So just because someone has shortness of breath doesn't mean there's something wrong with their lungs always. It could be a lot of systems there's something wrong with. So heart attacks, blood loss, shock will make people breathe really fast. They feel like they need more air because their body's not getting enough oxygenated blood. All right. So 4 minutes is the limit that your brain can go without oxygen. Once you go over 4 minutes, you're going to start to see brain damage and irreversible injury and deficits when that person wakes back up. So stroke-like deficits, cerebral palsy-like deficits, those come from not having enough oxygen to the brain. All right. And we do not diagnose breathing problems. This is a common theme in EMS. We're not necessarily diagnosing, but we can assess someone and look for things that are immediate threats and then stabilize and treat those immediate threats. That's always the name of the game. So it's not super important that you get a diagnosis. You don't need to say this person has a PE. You just need to say this person looks like they could use more oxygen and they look like they need to go to the hospital. That's what you're concerned with in EMS, not necessarily diagnosis. All right, so we're going to review some major anatomy and then we'll move on to some cases. All right, who remembers upper airway versus lower airway? We talked about this a while ago in our anatomy survey, and we went through it like a whirlwind. Who can tell us where the upper and lower airway are differentiated? I see Kelly
Larynx.
motioning. What was that,
Epiglottis.
Dean?
The larynx.
Yeah, good. So I heard larynx and epiglottis, which are both right, kind of on top of each other. The epiglottis covers the larynx. Both of those are great answers. Anything above the voice box or epiglottis is going to be the upper airway. Anything below is going to be the lower airway. Again, just useful in communicating. Upper airway trauma, you know that's going to involve the face, the mouth, the throat. Lower airway trauma is going to involve the trachea, the lungs, the bronchi in here. And what's this big old muscle here?
Diaphragm.
Diaphragm. It is labeled. That's too easy for y'all. Okay, good. So diaphragm is that big old breathing muscle, pulls the lungs down and opens up that space. Okay. This is the breakdown of air. Remember this came up last time in airway emergencies, 21% oxygen is in the air. If you exhale a breath, that breath contains 16 to 17% oxygen. So that is a totally usable form of oxygenation for someone if you're giving CPR. So that's something useful to come out of these random numbers. Just know that even your breath out contains a reasonable amount of oxygen, can be used to oxygenate someone else. All right, and then this is gas exchange in the alveoli, is driven by air concentrations. So what they're talking about is the alveoli are the little sacs in here where the gas actually goes across into the blood. And we're just saying that carbon dioxide comes out of the alveoli and oxygen goes into the alveoli. And here are those little sacs. So this is the site of gas exchange. They are really tiny. They're 70 million packed into your lungs. So these are like microscopic, very, very small. They are 1 cell thick, and that allows them to actually take oxygen through that 1 cell into the blood. If they were thicker, it'd be hard for oxygen to get through, but they're very thin. There are tons of them, and that gives your lungs just a lot of area to pick up oxygen. All right, so oxygen moves into the blood, carbon dioxide moves out. Once oxygen gets into the blood, it binds to hemoglobin, and it's carried throughout the body. So if you have a red blood cell, it's got hemoglobin in it, which is what carries oxygen. You have your oxygen over here, kind of attaches to the blood cell, and now your red blood cell, the hemoglobin is carrying oxygen. That's good because you want that hemoglobin to take the oxygen and dump it somewhere else in your body, like your muscle, your brain, your heart. That's the carrier for oxygen to get into your body. And what do we use to assess a patient and see how well their hemoglobin is carrying oxygen? We want to say, hey, does this person have oxygen in their blood attached to their hemoglobin that they're dumping off at their brain? Or is their blood just empty of hemoglobin? It doesn't have oxygen. We actually have a tool to look at someone and say how much of your blood has hemoglobin bound to oxygen. Does anyone know what that tool is? We've talked about
Pulse
it.
oximeter. Pulse
Yeah, exactly.
oximeter.
Right, that's the pulse oximeter. It gives you a percentage, and that percentage is how many of your blood cells are empty and how many of them are bound to hemoglobin. So if you have 99% oxygen saturation, that means 99% of your blood cells are carrying oxygen and they're ready to dump it off somewhere. That's good. If you have 85%, that's not so good. That means a lot of your blood is empty of oxygen and it's not doing anything for your body. All right. So respiratory rate and depth are controlled by the amount of acidity in your blood. So your blood has an approximate pH or acidity. I would imagine we've heard of pH in chemistry class. What pH means is just how acidic something is. And the blood pH ranges from about 7.3 to 7.4 in there. That means it's almost neutral. A pH of 7 is neutral, like pure water has a pH of 7. So blood is almost neutral pH, which makes sense. It's not going to be acidic, it's not going to be basic. And so what this tells us is that if your body measures a pH that is acidic or basic, it's going to react to that by trying to breathe really fast or really slow to correct it. And this gets somewhat complicated and we don't need to go into all of it. But what you can take away from this is that deep breathing or really fast breathing or really shallow breathing it can be a reflection of an imbalance in blood chemicals and an imbalance in blood pH. So if someone is septic, like they have a bacterial infection, that will mess with the pH of their blood, and that will change their breathing. Or if they're diabetic and they have a pH disturbance in their blood, that will mess with the pH, and that will change their breathing. So you just want to keep that in mind when you see someone who is maybe down and unconscious and they're breathing really fast or they're breathing really slow. They could have some sort of chemical issue going on. It could be a substance ingestion. It could be a disease like diabetes or a bacterial infection. So you want to think that not all respiratory issues are because of the lungs. Some of them come from the body and just imbalances in the whole body and the blood. So you just want to keep that in mind. Not every breathing issue is going to come from the lungs. Sometimes they're a bigger picture. All right. And carbon dioxide in the blood is detected by sensors in the carotid arteries and in the aorta, that big blood vessel in your stomach. And they tell your brain when you have a bunch of pH or a bunch of CO2 in your bloodstream, that's going to signal the brain to increase your breathing. So that's how your body actually decides how much to breathe, is based on the CO2 that is dissolved in your bloodstream. If there's more, it'll say, we got to get rid of the CO2, and it'll make you breathe faster and deeper. All right. So it's the amount of carbon dioxide dissolved in the blood that controls breathing, not the amount of oxygen in the blood. And who can tell us, why would having a bunch of carbon dioxide build up in your blood, and then your body senses that through these receptors in your aorta and your arteries here? Why would the body, in response to a lot of carbon dioxide, make you breathe faster and deeper? Because that's what happens. It senses all this carbon dioxide, and now all of a sudden the body says, I need to breathe a lot in response to all of this. Why would that happen?
It has to push it out.
Yeah, good. And Kelly, did you want to add to that?
Yeah, so I was going to say, was your heart's going to pump faster so it can oxygenate the blood quicker?
Yes, good.
So the toxin or the deoxygenated blood?
Mm-hmm. Yeah, good. So it's both of those, actually. It's what Dean said is it wants to get rid of that carbon dioxide, which is true. So we talked about a while ago, carbon dioxide is a waste product for your body. So your body doesn't want to hold on to it. It will mess up the pH of your blood. It will make it more acidic. And so your body wants to breathe out the carbon dioxide and get rid of it. And it's also this indirect sensor for what Kelly's saying, where your body knows that if a lot of carbon dioxide is building up, you're probably also not inhaling any oxygen. So another thing that it's doing is saying, well, if we have all this CO2, we're probably not breathing in any oxygen. So it also wants to speed up the breathing, and it'll speed up the heart rate as well to oxygenate the blood better. So good, those are the two things. It wants to get rid of that CO2 so it doesn't make your blood acidic, and it wants to bring in oxygen. All right. Inhalation and exhalation, we all know what that is. Inhalation in, exhalation exit. Ex always means out in medicine. That's a good root word. It's just Latin for out, ex. So exhalation means air out, inhalation in. I would imagine we're good with that. All right. So these are very important qualifiers in EMS and in medicine in general. These are the ways we describe breathing. So rate, rhythm, quality, and depth. So when you describe someone's breathing, you want to be attuned to all of these things. You don't want to just say they're breathing 30 times per minute, because those could be 30 really shallow breaths, in which case that's not enough breathing. Or if someone's breathing 30 times per minute and all of those are really deep breaths, that's probably too much. That shows something weird is going on. So you want to give a good idea to someone who you're giving a report to, sort of how someone is breathing. So let's do a little exercise here. I'm going to breathe, and it's going to be kind of weird, but you guys are going to watch my breathing and try and qualify it with this rate, rhythm, quality, and depth. Okay? So I'm going to breathe. You can see me on camera. Go ahead and just try and note these things to yourself. How is my breathing? Okay? So I'll go. Okay. So my rate of
You're gonna
breathing.
pass out.
Yeah, I probably would if I kept doing that, right? And that is a good thing to note. So my rate of breathing, we don't need to do numbers, but was that fast, slow, or normal?
Fast.
Fast. So you could say breathing, you might want to try and like ballpark, maybe say it's like 30 breaths per minute, or you could just say breathing faster than normal rate if you didn't get a number on it. What about my rhythm? Did I have like a regular rhythm or an irregular rhythm?
Irregular.
There's a couple of irregulars in there.
Sure, so maybe it was a little off, somewhat regular, somewhat irregular, not crazy, but not totally normal. What about the quality of my breath? Did my breath seem clear? Was I like gurgling or snoring? Was there anything weird about it, or were they pretty normal breaths?
Normal.
Normal.
Yeah, I wasn't trying to trick y'all. I was breathing pretty normally. But what about the depth of my breath? Was it normal,
Very
shallow, or deep?
Deep.
Yeah, it was very deep breathing, right? Good. So in all of that information now, you can kind of rattle that off quickly. You can say this patient was breathing above average rate, irregular rhythm, normal breaths, but they were very deep. So you can kind of quickly give someone a picture of like, oh, okay, so this person was breathing fast and deep and no secretions, nothing wrong with the breath. They're just breathing fast and deep. So it's a way to give someone a full picture of breath kind of quickly if you use these qualifiers. And then that can point you in a certain direction. We're going to talk about these respiratory emergencies, but they all have different kind of ways the breathing will manifest. And so this can help you communicate that. All right. And these are normal respiratory rates. So infants can breathe very fast. If you watch them, you can start to get kind of nervous because you're like, is this normal? And yes, it is normal. They breathe really fast. Children too, they can breathe 15 to 30 breaths a minute. Adults, pretty relaxed, 12 to 20. That's going to be a breath every 5 to 3 seconds. So adults should not be breathing that fast. All right. Time between each breath. Breaths should be equal. Time between them should be equal. I think we know what normal breathing looks like. And during exercise, we breathe more. Imagine that. All right. And then for quality, this is something you kind of get a sense of with more experience, but you're looking for like abnormal sounds. So what are some abnormal things we've talked about that could give you an abnormal breath sound? What are some things you might be looking for? If you're listening for breath, what could you find?
Wheezing and snoring and
Good. So we have wheezing, we have snoring. What else?
Gurgling.
Gurgling, that's a good one. So wheezing is like airways closing up. Snoring is the tongue is obstructing the airway. Gurgling would be some sort of secretion is in the airway. So you can learn a lot just listening to someone's breath. You can get a really good picture of what's going on with them globally. Good. Those would be some main ones. Anything else I'm thinking of? Yeah, we'll move on. I can't think of any others off the top of my head. And then depth is just the volume of each air taken.
What causes stridor?
Oh, stridor, that's a good one. So stridor is going to be it sounds sort of like a trumpet, and a trumpet, or that's how people sometimes describe it. And a trumpet is made by forcing air through a small hole. This is how I remember it. And so stridor is when your upper airway swells. I'll go back to this upper airway image. Stridor is when you have swelling in your upper airway, sort of in the larynx or in the upper trachea, and you get it narrowing down to a small hole, usually because of a viral infection. This usually happens in kids because of viruses. And what happens is then when they try to force air out of their airway or into their airway, sorry, it's usually on inspiration. You hear the air being forced through that small hole, and just like a trumpet makes a really like brassy sort of horn noise, that's what stridor sounds like. It's like this weird like sort of horn-like squeal that comes from air being forced through a small hole because their airway is swollen right here. Or if you have a foreign body, like if a kid swallows a coin and it's covering most of their airway but not all of it, you can also hear stridor as the air passes through that little space. So stridor is air being forced through a little space, and the little space is either caused by inflammation or obstruction by a foreign body. Okay, so it's a bad one too. That's stridor means that the airway is almost closed. So it means this kid has either like a significant viral infection that is causing them breathing difficulty, or they swallowed something that is causing them breathing difficulty, or rather inhaled it. So stridor means the airway is almost closed. But good question. Okay. All right, good. So that was a good review of breathing physiology and a little bit of anatomy. Any questions before we move on? Okay. All right. Choking. Of course, we must maintain gas exchange. That is what breathing is. The tongue, we've talked about this, is the most common cause of airway obstruction. What are, let's see, 3 things you can do to remove a tongue from the airway? What are our main tools there?
Opa.
Gravity.
Okay, that's a good one. I wasn't even thinking that. So we've got OPA or OPA. I like that. Gravity. 2 other things.
And chin lift or the jaw thrust.
Good. Okay. Head tilt, chin lift / jaw thrust. I was counting those as 1 in my brain, so I still have 1 more I'm thinking of. We have OPA. We have gravity, like recovery position. We have the head tilt, chin lift or jaw thrust. What's our last airway intervention that we use?
NPA.
NPA. Perfect. We can put in an OPA or an NPA. Good. So anyone who is unconscious and their tongue is obstructing their airway, we know what to do now. All right. This usually happens with people who are laying supine. If they're laying down, remember supine means on your back. That's when your tongue is going to fall into your airway. All right. Foreign bodies that get past the epiglottis. We talked about the epiglottis covers your trachea. When things get past it, they go into the trachea and they clog it.
Can I ask a quick question? I want to clarify. You said OPA with the tongue retracted in the throat or towards the throat?
Yeah, if a tongue is falling back in the throat, you can place an OPA.
All right.
Clarifying
I'm just
point?
worrying about it already being sort of in a position. How are you going to make sure that it's forward before you try to put the OPA in?
Oh, sure. No, that's a great question. So there is a technique to putting an OPA that we showed it in pictures, but you kind of have to practice it. And in our in-person sessions, you'll get to practice this on a mannequin with a little fake rubber tongue. But the way you put it in is you put it in upside down and with the curvature kind of facing the roof of the mouth. And as you put it in, you kind of twist it and you're supposed to sweep the tongue and kind of like scoop the tongue forward as you place it so that you end up with a little curvature going back behind the tongue. So that's a great question.
I can see how, yeah, I just didn't want to put one in and force it further back, you know?
No, that's a great question. And so you do be cautious of when you're putting it in, it's got the curve on it and the curve is meant to actually catch the tongue and sweep it out of the way. So yeah, we'll show you how to do that in person, but that's a great question. Okay. And then these are the ways we can remove obstructions from the airway. You can do a finger sweep, you can do suction, gravity positioning, and then abdominal thrusts. So this is if you suspect like a foreign body in the airway. Let's see. All right, asthma. I would imagine we all have heard of asthma by now. So asthma is just a closing of the lower airways. Remember, upper versus lower. So asthma happens in the lower airways. It's going to be those little bronchioles. They're these little, right before the alveoli is the bronchiole. So they're really tiny, small tubes. And in asthma, they just constrict because of basically allergies. Your body just has this reaction to small particles in the air, and it reacts as if it's allergic to those, and that causes it to constantly kind of close up. And so people are having to take medicine to fight this pretty constantly. This is something that is common. You might see people having an asthma exacerbation, and you'll know how to help them. So the exact cause, like I said, it's sort of allergic. You can't pin it to anything exactly, but we know it's mediated by the same chemicals as allergies and this like reaction to something in the air that just causes things to swell, just like your face swells with an allergic reaction. Oh yeah, and here, environmental triggers such as pollen in the air can stimulate a reaction, resulting in inflammation and mucus. Another thing that happens is exercise can induce asthma. So someone who really does a lot of activity, so like skiing, could trigger asthma to get worse. Also, cold air can trigger asthma to get worse. So you might get some tourist who never goes to the mountains and they never go skiing and they have asthma. And now all of a sudden they're at this double whammy where they're exercising and they're in this cold air that could trigger their asthma. So that is certainly something you could encounter because these people can be highly functional. They can work out, they can play sports, but then something will just set them off and they'll be having an issue. And then status asthmaticus is something that involves a severe asthma attack that cannot be fixed with medications alone. All right. I would say a good rule of thumb with any respiratory emergency is going to be ALS transport. You never know how these are going to react. So if you have someone with asthma, even if they have an inhaler, if they have an exacerbation, if their asthma, all of a sudden they have an asthma attack, you can give them their inhaler, but you can never be sure that that's going to fix their problem. So I would not count on that. I would not count on them saying like, oh yeah, I have asthma, this happens, I have my inhaler, but I'm really having trouble breathing right now. If you think there's any possibility it would stay the same or get worse, then it's ALS transport for a breathing issue. You can always cancel the ambulance, but treat these people with caution. All right, COPD. Any questions about asthma before we move on? Okay.
Actually, yeah. The book
Yeah,
said
please.
that you have to make sure their inhaler is their prescription and all that stuff. Are they really that different, or are they all pretty much the same dose of the same medicine?
Yeah, it's a good question. They are different in that some of them are like controllers and some of them are actually short-acting treatments. So this actually can happen where patients will, they'll say like, oh yeah, like I'm having an asthma attack, but like my friend has asthma and they have an inhaler and I'm just going to use that. But their friend's inhaler is actually like a steroid that just controls them over the course of the day, and it won't actually help them in the short term. It just kind of provides base level control. And in that case, you're not going to get anything out of that. If their friend has the same inhaler they use for short-term relief, then it would work. So it's kind of up to you if you want to let someone say like, oh yeah, this is my medication, and they really want to try and treat it themselves. That's up to them if they want to take a medication that they just have access to. I would just be careful in thinking like, this might not be what they need. This might not help them. You're in kind of dicey territory there. We can't stop people from taking meds that they have access to, but I wouldn't count on it.
All right, thanks.
That makes sense? Yeah,
I
sure.
wasn't sure just how much different they were.
Yeah, no, most of them, the ones that do short relief are the same, but some of them are for long-term relief and they'll do nothing in the short term. So you want to be careful. All right, so COPD. This is chronic obstructive pulmonary disease. So broken down, COPD just means that chronic long-term, you have obstructions in your lungs. Pulmonary means lungs, and it's a disease. So COPD is just you have a long-lasting lung obstruction, and that is usually from smoking. Sometimes it's caused by having asthma for a long time. Sometimes there are other things that cause it, but it's usually from smoking. You just constantly irritate your airways. You're going to develop some obstruction, some inflammation, some scarring, and then you're going to have COPD, where it's more difficult to breathe. So you'll have constricted tubes in your airway, and it'll cause you to have difficulty breathing, cough, mucus production, and wheezing. Most often caused by cigarettes. This is actually a high leading death in America, because you can have, just like asthma attacks, you can have COPD attacks, and most people never expect this. They'll just be smoking cigarettes all day and having a little trouble breathing, and then one day their airways just close up, and that is an emergency. So if you see someone who has a smoking history, and usually they're fine, they have no trouble breathing, I don't know what happened, now they just can't breathe. This happens pretty commonly, and it is an emergency. It's the third leading cause of death. So like when you hear that cigarettes kill X amount of people per year, a lot of that is lung cancer, but a lot of that is just the COPD exacerbations, where people have COPD attacks, the airways close up on just any given day, and they don't make it to the hospital. So you want to watch out for this. Always ALS can be treated by improving oxygenation. So you can always give oxygen. All right, there are two forms, chronic bronchitis, chronic emphysema. Not really useful in the field. I mean, if someone has difficulty breathing and you know it's from smoking a bunch of cigarettes, it's going to be treated about the same. Both develop over a lifetime and both cause hypoxia or not enough oxygen in the tissues. Okay, so chronic bronchitis is a form of COPD. It's just narrowing of the bronchioles. If I can actually go back, let's see. We'll just go to here, anatomy and physiology. The bronchioles are these guys. Bronchitis just means inflammation of the bronchioles. So if you hear that, itis always just means inflammation in medicine. Itis equals inflammation. So bronchitis is just inflammation of the bronchioles. You can imagine if you smoke cigarettes every day and your bronchioles are inflamed every day, they'll kind of just narrow up. You'll form scar tissue, they'll be swollen, they'll be full of fluid and kind of angry and inflamed. And over a lifetime, they'll just get smaller and smaller, and eventually we'll have a lot of trouble breathing. So that is what chronic bronchitis or COPD is going to cause. Okay. And emphysema is the same thing, just at the level of the alveoli. And if someone has a question out there, please let me know. All right. Hyperventilation system is a panic attack, basically. It's caused by excessive breathing or hyperventilation. The body's response to psychological factors, anxiety or panic, or like we talked about earlier, sometimes really deep, fast breathing is the result of like a chemical imbalance in your body. It's something like diabetes or maybe an infection. So other things can cause you to breathe really fast, like I was showing earlier. This is usually benign. You want to be careful. Panic attacks are benign. Usually people will you can coach them to calm down. Even if they pass out, they'll usually just wake right up once the blood gets back to their brain. But you do want to be careful assuming anything is benign in EMS. That's always something you want to watch out for. All right. And it can mimic other things that are emergencies like heart attacks, diabetes, or head injury. So that's why you want to be careful saying that something is benign. Has anyone ever known someone who had a panic attack or seen someone have a panic attack and they get like the hands and feet kind of like tighten up? Anyone ever seen this in a friend or something? It's kind of strange. Okay, so just because of it's basically like calcium and carbon dioxide in your blood do this weird thing, but it causes your muscles. Together. What now?
Their hands, like it's like their fingertips pinched together towards each other. They're like little hands.
Yeah, so it basically just causes your muscles to have spasms. And so this is how you can kind of tell someone is having a panic attack probably, is if you see their hands are kind of like doing this and they're like kind of shaking, or they do this weird like spasm thing with their fingers and their toes. And it has to do with chemicals in your bloodstream that are just thrown off by breathing this much. But if someone's kind of like this and like their hands are being weird and they're breathing really fast, and you say like, hey, do you have tingling in your hands and feet? Do you have tingling in your lips? Those are all signs of panic attack. You can review them right here. You have peripheral tingling, spasms in the hands and feet, chest tightness. It feels like they don't have enough air. They're kind of freaking out. And you'll see a few, and then you'll kind of start to get it where you're like, oh, okay, I recognize this now. But initially they can be kind of scary because these people are really worried for themselves. They're really worried about not getting enough oxygen. They're kind of freaking out, and that can kind of make you freak out. But as you see a few, you'll kind of think, oh, like I've seen this before. It has this very characteristic look to it. So something that we will keep, you'll want to go back and look at signs of all these, but this is a good case of a panic attack. It usually does look like this. All right, pulmonary embolism. This is where a blood clot goes in your lung. The pulmonary artery is the artery that goes from the heart to the lung. So a pulmonary embolism just means lung, pulmonary, and an embolism is a blood clot. So pulmonary means lung, embolism means blood clot. A pulmonary embolism is a blood clot in your lung. This is an emergency. They can block off a large enough section of your lung that your body cannot get enough oxygen. And so this is certainly an emergency. Clot breaks loose, travels through the heart, and lodges in the lungs. This disrupts blood through the lungs, prevents gas exchange. So this is fatal if it occurs in a large enough artery. This one is certainly an emergency. The way this is going to happen is anything that keeps you from moving is going to give the blood in your foot a chance to clot. So you know how quickly blood clots, if you get like a cut on your hand, it only takes that maybe 15, 20 minutes to stop bleeding completely. It's pretty amazing how good blood is at clotting and blocking up holes. It's for survival reasons. But if you, for a long period of time, don't move your legs at all, then this can have a negative effect and the blood in your leg might start to clot. Even with movement, like your heart is pumping, it's trying to push that blood, but if you don't move your leg at all, then you can cause that blood to still kind of stick in there like jelly. And that gives it a chance to clot, and then that clot makes its way to your lung. And that's how you end up with the pulmonary embolism. So anything like prolonged sitting, if you break a long bone and you have to get it put in a cast and it doesn't get to move at all, if you have surgery and you have to lie in bed for like 5 days on end, that could give you a blood clot. And then for other reasons, heart disease, pregnancy, you're not going to be moving much with these either. And if you have a clotting disorder. Okay. So if you have, most pulmonary embolisms are small, but large blockages cause severe hypoxia or even shock and death. And we should definitely know this word hypoxia. Who can tell us what does, well, hypoxia says a decreased amount of oxygen reaching the tissue. Who can break down this word for us? Because this is a good skill in medicine. We have two halves of this word. We have hype and we have oxia. Who can sort of break down this word and describe to us, why does hypoxia mean low oxygen? Anyone want to give that a try?
Hypo means low, and the oxia is oxygen concentration.
Yeah, say that again, Razvan.
Yeah, so it's hype is from hypo, like hypo means low.
Mhm.
The oxia is the concentration of oxygen in the blood.
Very good. So this is a great skill in medicine to be able to break a word down into its roots. It'll tell you what it means. Hypo means low, like hypo means below, like hypothermia is low temperature. And of course, oxia means oxygen. So hypoxia just means low oxygen. It's right there in the word. So that made it easy for me to learn these words. And if you're learning these words, it can always help to kind of break them down into their roots. It can help you guys too. Similarly, we have anoxia. What does an mean here? We know that oxia means oxygen. What does the a or the an mean in this case?
Lack of oxygen.
Lack of.
Yeah.
Yeah, it means lack or absence of. So in this case, anoxia means no oxygen. Okay, very good. That'll help you with any medical word. I encourage you to get used to doing that. It makes it easier to learn. All right, a big PE is called a saddle embolus. That's because the big artery right here in the middle of your chest looks kind of like a saddle. If you get a PE big enough to lodge right in that giant artery in the middle of your chest, that is almost always fatal. Any PE should be treated the same though. If someone has pain and difficulty breathing, you just give them oxygen transport. These are kind of arbitrary classifications. They're going to be treated the same. All right, any questions on PEs?
So one of the questions is list the signs and symptoms. Is there really a way to distinguish that as opposed to something else?
That's a great question. What's difficult about breathing troubles is that A lot of them will involve two things, and that is a feeling that you don't have enough air, which we'll describe as shortness of breath, and chest pain, which is going to be because you're not getting enough oxygen. That makes your heart hurt. So a PE actually causes the same things. It causes shortness of breath because you're not getting enough oxygen, and it causes chest pain because you have a blood clot in your lung, which is very painful. It's causing pressure. It's causing death of your lung section. So that'll also cause shortness of breath and chest pain. A heart attack will cause shortness of breath and chest pain. COVID will cause shortness of breath and chest pain. Pneumonia will cause shortness of breath and chest pain. So the trick in these, since they all come with shortness of breath and chest pain, the trick in distinguishing these is usually the nature of the chest pain. So if the chest pain feels like this squeezing, like I have an elephant sitting on my chest and it's radiating to my jaw and my left arm, what sort of chest pain might I be describing?
Heart attack.
Heart attack, exactly, an MI. So that lets you know that that short of breath and chest pain is probably an MI. If I have something like a really sharp, it's described as a pinpoint chest pain, like I can localize, like it's right here. And every time I take a breath, it hurts right here, like someone's stabbing me with a knife. That is a classic PE, or pulmonary embolism. That's like classic for that. The issue though is that these things will often be blurred. So textbooks like to play them a certain way, but when you actually get a patient, they might not be that easy to qualify. They might just say like, the right side of my chest is burning every time I take a breath. And you're like, what do I make of that? I don't know. And so really the bottom line becomes you can try to distinguish them by these textbook definitions. That is helpful. Sometimes it will be that easy, and sometimes you'll have a good idea based on the presentation. But like we said earlier, the biggest thing in EMS is not a diagnosis, but a treatment. So you just say, what can I do about this? Can I fix their breathing difficulty? Can I address their airway? Is there an issue there I can fix? If not, you move on to breathing, say I can give you oxygen. And then if it looks serious, you say I can get you an ambulance. So it can be useful to try and make a guess and say this person looks like they might have a PE, but the biggest thing is just going to be treatments and transport. And that will be pretty similar for all of these. Does that make sense, Bragg?
Yeah, for sure. Thanks.
Okay, good. And yes, that was a really long answer, but for a PE, it's pinpoint chest pain every time you take a breath, sharp chest pain. That's the classic PE. All right. Pneumothorax. This means a lung has collapsed in your rib cage. So it's an accumulation of air in this space you can see here. This can be from trauma usually. So like a broken rib can cause this. Your rib pokes your lung and now your lung deflates. And this will cause you, again, chest pain because it hurts and shortness of breath. This one also causes kind of a sharp pain because you've punctured your lung. So the bottom line here is you need oxygenation, you need transport. The upside to this though is if you can guess, so it can kind of be back burner issue, but if you feel confident that you know what you're dealing with and you have something like a PE, it can be helpful, or sorry, not PE, a pneumothorax. It can be helpful to give these patients positive pressure ventilation. You kind of help force air into this lung that has collapsed. So there is some utility sometimes in figuring out, okay, you have a breathing difficulty. I'm not sure, but I think it might be this. And I think this intervention specifically might help you. So for something like this, a pneumothorax, you could give someone positive pressure ventilations, like with a BVM, with the bag valve mask. You could give that to them. That would help push air into this lung. That's going to come with experience. That's not really, I wouldn't expect you guys to get up on the hill and be like, I can figure this out. I know this is a PE, this is a pneumothorax. That comes with experience, but looking forward to your question, Bragg, of like, how do I tell this one versus this one? There is some utility in that because some of these will have treatments in the field that you can use. All right, but this is, yeah, question?
Greg, yeah, I want to bring up more like a question, I guess.
Yeah, please.
As far as I know, probably one of the first things that you can do in the field for a punctured lung is to actually seal the thoracic, the chest cavity, like the wound, basically.
Yes.
So
Yeah,
that's
absolutely.
that can be done in the field, and it's probably the first thing that you can do.
That's a great point. And we have a whole section on chest trauma. And so if you are doing an inspection and you see an actual puncture, like you know this person hit a sharp tree branch or something, and
Yeah.
you see a puncture wound in the chest, and you actually see blood kind of gurgling out of that, then absolutely, you're right. You can totally do a traumatic dressing for that. You can do a dressing that keeps the air in. So yeah, very good. All right, and we will have a whole section on chest trauma. All right, and then sometimes it'll be harder, like you'll see no actual like entrance wound. Sometimes it's just a broken rib that punctured a lung and you don't see like a puncture, but the rib broke and did it. So sometimes it's harder, but sometimes you can uncover it. All right. So the most common cause of this is traumatic injury to the chest wall, the ribs, the lung itself lets that lung deflate and the air goes into the pleural space is what we call this, instead of into the lung. All right. And then less commonly, chronic emphysema. This is a COPD, like someone who smokes every day, or a severe asthma. Again, you have this lifetime lung issue. Can cause your lung to just become fragile and it can spontaneously rupture. I actually have a friend who this happened to. He's a really tall, skinny guy. And sometimes like your lungs just, they get fragile, they rupture, and that can happen out of nowhere. So it can be on your differential for someone who's just standing there and has chest pain breathing for some reason. Kind of an odd case, but it is possible. All right. So the problem may go away spontaneously, or it may cause a complete lack of oxygen in that side of the lung, causing emergent hospital care. What do you all think you should do, regardless of if you think this might resolve spontaneously or might get worse? What do you do no matter what?
Call an ALS.
Yes, ambulance and one other thing, transport and O2. Good. Yep. Just about every breathing difficulty, we're talking about these differentiations, but all breathing difficulties are treated seriously. Every one of them should get ALS and oxygen. All right, here we have COVID. I'm sure we'll get a lot more talks about COVID from the resort. I think we all know what COVID looks like at this point. Just be careful. We'll have N95s available to us on the hill. We'll be wearing masks at all time. So remember your PPE. Remember gloves, mask, goggles to keep yourself safe from diseases. All right, patient assessments. We'll take a break in a few minutes here. We know this, scene size up, ABCDs, AVPU scale, stuff that we've gone through before. Patient's overall appearance, what's the scene looking like, what's going on with this person. These are kind of just scenarios of like what a person who has each of these will look like on approach. Again, this kind of comes from experience, but someone who has chronic bronchitis is a smoker with other conditions. So you can say they'll be overweight, they'll cough a lot, they have a smoker's cough basically. They'll kind of look out of breath, maybe a little pale, and they'll be working really hard to breathe. So this is just trying to paint a picture of chronic bronchitis. As you see more of these, you'll kind of pick them up. Emphysema, similar, but usually not overweight. They're usually thin. That's because emphysema causes your metabolism to go up. They don't go into that. Again, they'll just look like they're having difficulty breathing. Asthma, very anxious because an asthma attack is a very scary thing. They'll have quick, shallow breathing. Maybe wheezing is the big one here. And that's a sound caused by narrowing of the airways. So I'd say they highlighted wheezing here for a good reason. Wheezing is a really good chance someone has asthma or an allergic reaction to something, and that's something you can do something about. So it's good to key into specific signs like this. All right, PE, again, cyanotic, blue, they're not getting enough oxygen, panicked, have deep, rapid respirations, maybe unresponsive. As I'm reading through these, it's kind of difficult. What's striking me is that a lot of these people look the same. Like I said earlier, a lot of them, they won't be getting enough air, which causes them to freak out. which they should be, they will look kind of starved for air. They might be kind of pale. They'll be breathing really fast. They might say they have chest pain. And a lot of them are difficult to tell what's going on. So rather than focusing on a differential like, oh, is this a PE or is this hyperventilation syndrome? I would worry about your primary assessment. Say, does this person have an airway issue I can fix? Does this person have a breathing issue I can fix? Yes, you can give them oxygen. Do they have a circulation issue that I need to address? Check their pulse, see how their heart's doing. You can take vital signs. You can look at their oxygen saturation. I wouldn't get tracked up into trying to diagnose someone. I would just stay focused on your assessment and what you can do in the moment. I think these are here just for kind of academic reasons. And as you get more experience, you'll learn to recognize these. But early on, I would just say, focus on what you can do in the moment, and that is immediate interventions. What can I do to fix your breathing? What can I do to fix your airway? All right, and let's see. With that, let's see how close we are to a little break point. Not too close. Let's take a break here. We'll do 5 minutes and then come back at 7:01. All right, that sounds good to everyone. Come back in about 5 minutes here. All right, y'all. Whenever we're ready, I'll be ready.
Hey, Greg,
Yeah, Patty.
I need to have everyone sign in like they did the other day.
Okay.
Does everyone remember how they signed in? Hopefully. They
Yeah,
do.
just type in the chat.
Like in the chat box?
That's it. That's all I need to know. Perfect. This way you get credit for the day, for the evening. I was going to do it at the beginning, but I decided to do it in the middle.
How do I do that, Patty?
You just, there's a little box that says,
Oh, chat. There you go.
and then just put your name in. We have Michael that has joined us. Greg?
Hey, Michael. I'm Greg.
Hey, Greg. Nice to meet you.
Good to meet you. Welcome.
And the group.
All right.
Hi, everyone.
Welcome, Michael.
I also wanted to say that David Worley will be leaving us for a while. He is going to open up the hotel restaurant area that used to be the Rock. What is it? The Hard Rock.
Oh, wow.
So
That's
he's
great.
gonna have to leave us,
That's
Dang.
awesome.
but he's going to be back. He's not going to quit. He's just
Yeah.
not going to participate for a while. Okay.
Okay, cool. Yeah,
So
he
I
was,
said we're going to
always
all miss
pretty-
him.
Okay. We'll miss him. All right. We have, we should be able to run through the remainder in about an hour here, and then we'll have the last hours for just some review time. So it'll be a little more engagement heavy towards the end. But we got one more hour to cover just respiratory emergencies. So reviewing what we talked about in the beginning, let's just go over some key points. So everyone who has respiratory emergency, what are the two things that you're going to want to get for them?
Oxygen.
Oxygen.
And
Transport.
yes, always ALS, always oxygen. Good. And then if we're describing someone's breathing for a report or for another person down the care chain, what are the qualifying words that we want to use to describe someone's breathing? We learned 4 of them.
Rate, rhythm, depth,
Quality, depth.
Quality.
Perfect.
quality. Yeah.
Yep, perfect. Rate, rhythm, depth, quality in no particular order, but very good. All right. Any other questions before we get into the last half? Okay. So the hallmark of a respiratory-related emergency is dyspnea. Breaking down words again in medicine, all these words are made of like different Latin words. Dys just means like painful or abnormal, and pnea means lung, basically. Like pneumothorax means lung, pneumo means lung, and this is the same sort of word. So this just means you have pain on breathing or difficulty breathing. And so they're just saying the hallmark of any respiratory related emergency is pain or difficulty breathing. That makes sense, right? But if you ever heard this word dyspnea, it just means difficult or painful breathing. All right, so learn to recognize the signs by looking at someone. So signs of respiratory distress, choking or gagging. I think we could all recognize that. People are really good about giving the choking sign. I don't know what it is. Humans just know how to do that. Inability to speak. You know, if someone can't even get words out because they're breathing so hard. Red flag. Open mouth breathing, panting, gasping, breathing like through pursed lips. I think we can all recognize when you see someone having difficulty breathing, if you think, oh, it looks like they're having a hard time breathing, they probably are. I think as humans, we just recognize that innately. So go with your gut on that. All right. Again, this word pnea just means lungs or breathing. It kind of means both. Tachy in medicine means fast. So tachypnea means fast breathing, greater than 30 respirations per minute. And brady means slow. So bradypnea or bradypnea, it's kind of a weird one to say, means less than 10. So knowing these words, what would a tachycardia mean?
Fast heart rate.
Right. So tachy means fast, cardia means heart. So tachycardia is fast heart rate. Similarly, bradycardia is going to be a slow heart rate. So learn how to break down these medical words. Cyanosis, remember cyan means blue. So cyanosis is like a blue tint to the skin. It's going to be a sign you're not getting enough oxygen. So you can see this kind of bluish color to these fingers. That's cyanosis. Cyan means blue. All right, nasal flaring, just a sign you're having difficulty breathing. The tripod position is, if you look at my camera here, it's when someone sits, I sit like this, they sit like this so they can like really have help breathing. You can kind of try it yourself. If you are really trying to breathe deeply, the most comfortable position to be in is going to be like with your head kind of pushed forward so you can like really open up your chest. When you see someone having really hard time breathing, they'll often take this position on their own because it helps them get breath in. So if you walk up to someone, you see them sitting like this, trying really hard to breathe, that's a bad sign. It means they were really uncomfortable in a normal position and they had to go and sit like this just to be comfortable. So that's the tripod position, kind of a worrying sign. And then, of course, a change in a level of responsiveness is always bad. I mean, that means that they didn't get enough oxygen to stay alert and awake. Of course, that's a bad sign. All right. We just talked about the tripod position. I just showed you, you sit up with your leaning forward with your elbows out, kind of like sniffing the air with your nose. I encourage you all to try it. It makes it easier to get breath into your chest. You can see why someone would want to do it. But it's not a good thing to see in your patients. It means they were kind of forced to do that by a breathing problem. Let's, as an educational exercise, let's all try the tripod position. And this will help you remember it. So you're leaning forward, you put your hands on your knees and you kind of get like hunched over and you like stick your nose out to really, you can like really fill up your chest like that. So just remember, if you see someone in that position, that means they're struggling. All right. Especially children will have abdominal breathing. We call this belly breathing sometimes. You can see the abdominal muscles kind of like bubbling out to try and pull even more air in. So if you really expand your abdomen, you can pull even more air into your lungs, and kids will often do this. Basically, if you see anyone using muscles to breathe, if you see them using like their neck, they're like that. If you see them using their belly, like really moving their belly to breathe, if you see anyone breathing in any way that isn't just sitting there, breathing with their normal diaphragm and maybe the ribs, always bad. So they're going into abdominal muscles, maybe tripod, maybe the shoulders. No matter what it is, if someone is using these, we call them accessory muscles to breathe, it always means that they're having difficulty. It's always a sign that they need help with their breathing. So just something to look out for. Any sign that they're using extra muscles means they're having trouble. All right. So of course, obtain a sample history. We're doing our assessment. So things that you can ask for with this is like, what kind of started this? Like, did this come out of nowhere? Are you used to having this? Does something make it better or worse? Like, are you allergic to something? Did you just smoke a cigarette? Do you have asthma? Do you need your inhaler? So just trying to quantify like the nature of what's going on, maybe something you could do about it. And then of course, ask about medical problems and medications, because that could tie into this, and that will help you find out if the person has an inhaler. And if so, do they have it with them? So like Dean mentioned, often people will have their own inhaler, maybe even someone else's. Up to them if they want to take that. What you should probably recommend is, hey, I'll call you an ambulance. They'll have whatever you need. But if they have their own inhaler, for sure you want to use it for them. All right, and then you can identify associated symptoms like, does this person have a cough? Do they have a fever? Do they have chest pain? Do they have swelling in their extremities? All of these things are going to kind of push you towards different diagnoses. Like a productive cough would be kind of pneumonia or COPD. A fever would be more pneumonia, or a PE. Chest pain is going to be like a heart attack, or really any of them can cause chest pain. But it can help people down the care chain understand things about the condition, and it might help you uncover their condition as well. All right, and then you can ask about medical problems like blood clots, or any lung disease. If someone has difficulty breathing and they tell you I have COPD, that's pretty clear cut. You're like, okay, this is probably your COPD. We'll treat you accordingly. All right. If the patient's respiratory history includes respiratory issues, ask them how it compares to their previous episodes. This can be helpful because you can say like, oh, so you have asthma attacks sometimes. Does this feel the same or does this feel different, right? And they might tell you this feels exactly like my asthma attacks always do. And you're like, okay, good. Well, this is probably an asthma attack. But if they say I have asthma and this does not feel like any asthma attack I have ever had, well, maybe it's not an asthma attack. So it can be helpful to kind of ask them like, do you think this is your asthma? Like, does this feel like your COPD? Or does this feel like something different? Patients are usually pretty good at understanding that about themselves. All right.
Also, just
yeah,
say if
please.
they're having really hard time breathing, like to the point that they're in distress about it, it's sometimes easier just to ask yes, no, so they can nod their answers to you, because it causes agitation when they're scared and they're struggling to breathe. So, and the longer it goes on, they may get confused. Having been emergently intubated because of an upper airway obstruction, even though I knew exactly what was going on, even though, you know, I had training with this, there was nothing that I could do to stop that panic that was, you know, persistently starting to set in the longer it went on. So just, I know I couldn't answer questions by the time we got to the ER. I had no ability to. Colin ended up answering questions on my behalf.
Sure. No, that's a great point. So a lot of these patients will probably not be able to speak with you in the way that this detailed assessment we're running through is kind of implying. And that's a great point. So yeah, if someone, it's kind of a medical thing too, if someone is having so much trouble answering you that causes them even further shortness of breath, maybe you just don't ask them questions, because what's best for them, you knowing more or them getting enough air. So it's kind of a balance. That's a great point. And you want to take it into consideration, like some things you want to know, like, do you have asthma? Yes. Like, do you have an inhaler? Yes. Like that is worth it to figure out. But if you're like does pollen trigger this breathing? Then like probably not worth it. So great point. You're kind of working with limited words with these patients.
Yeah, and if it's a wheeze, it's an external thing only. It comes out and it's more musical noted, kind of has like a fluctuation to it. If it's stridor, it can be inspiratory or expiratory, but it's like a single note. It's just got a single tone to it, and it's really up close in the throat. It sounds like it's coming from the throat, not the lungs. So if that gives a little bit of determination or help for people worried about, can you tell the difference? That's something over with the experiences that I've had in the nursing field, that emergency and trauma nursing and whatnot. That's one of those things, a very distinctive difference. When you hear it, you'll know. One's coming from the chest on expiration, the other one can be in or out, but it's more from the throat.
Sure, absolutely. And if you trust your ability to kind of distinguish and base your care plan on what you think the nature of this breathing difficulty is, that's, yeah, absolutely. If you feel comfortable, can be good. And until you feel comfortable, just go ahead and like listen, try and pay attention, and try and, when you hear wheezing and someone says this is wheezing, then make sure you get a chance to listen and say, okay, that's wheezing. And you'll develop that sense too. Okay, good. And then they bring up something here, which is a good rule for EMS in general. Ask if you can walk a short distance without becoming short of breath, or if the patient is able to walk and they're just showing you that they can walk, that's usually a good sign. But if someone cannot even get up and take some steps because they're so short of breath or they're having an acute issue, worse sign. So that's a general rule in EMS. That's actually the way we triage patients in mass casualty situations. If you can walk, you're automatically lower acuity. That's reserved for mass casualties. You want to be a little more cautious than that in the field, but it's a good sign if someone can walk. If they cannot, it's a worse sign. All right, secondary patient assessments. So you want to make sure you cover other things. Like we said, breathing difficulties are often related to other issues. So you want to ask, do you have chest pain? If you can, if they are able to answer you, then you want to ask for related issues to make sure you're not missing something else going on. And of course, you want to kind of qualify this with duration of symptoms. You want to get more info surrounding it. So like, when did this start? How does this feel? Stuff like you said about, does this feel like an exacerbation you had before? Just any detail you can offer on any complaint is going to be helpful if you can afford to get that information. So any detail you can build into your report is going to help. All right. Here you can note how much the person can speak. So severe dyspnea means limiting 1 or 2 word answers. So like Liz was saying, maybe they can only get a yes or a no out, and that's all they can manage. You can note that to other care providers. That'll give an idea of how severe this is. And you can ask yes or no questions, like was pointed out. All right, do not ask open-ended questions. That's going to cause a long-winded answer. All right, skin color for pallor cyanosis. Pallor means whiteness, kind of like paleness. Cyanosis, that blueness. So look around the patient's eyelids, lips, and the nail beds. Those are going to be the first places you'll see this stuff. So usually lips and nail beds are going to be the easiest places to see this. The inside of the eyelids is going to be harder to see. All right. Let's see. Complete the rest of the physical exam. And we will go more into physical exams in like trauma. These things they're talking about here are more traumatic issues. We haven't really done the traumatic physical yet. But we'll get more into this later when we talk about crepitus, like bones moving, or Rice Krispie kind of crackly skin. Those are signs of trauma that we will be exploring in detail later on. All right, of course, complete set of vital signs. This is all part of your general assessment flow, always vital signs. We talked about rate, rhythm, depth, and quality of the breathing, especially important in a respiratory complaint. If someone says, I hurt my wrist, and they walk up to you and they're like, hey, can you like fix my wrist for me? You don't need to note in your report the rate, rhythm, depth, and quality of their breathing. Like it doesn't really matter that much. But if someone comes up for an asthma attack or for COPD exacerbation, then you do want to be noting stuff like this in your report. So you want to focus on what's important. And in this case, you want to be really detailed in your description of their breathing. And then this is just how you count. Remember we talked about if you're counting someone's respirations, you can take their pulse, you can put it on their chest, and you can watch, and don't even tell them you're counting their breaths because that'll mess up your measurement. Say, I'm going to check your heart rate. Take their pulse, you put it on their chest, and you watch their chest go up and down, and you count breaths that way. And that's a good way to count someone's breathing. All right. Vital signs change over time. So of course, repeat your vitals. How often do we reassess a critical patient versus a stable patient?
5 minutes
versus 15.
or 15, yeah.
Perfect. 5 for a critical patient, 15 for a stable patient. Airway complaints are going to count as critical patients. An airway issue is something that can change very quickly, so you want to watch it. I would say it's not like an every 5-minute thing. Like when you have these people in your care, you should always be watching their airway. You should always be watching the quality of their breathing, not just paying attention every 5 minutes. You record it every 5 minutes, but you should always be keyed into like how well are they breathing, because that's what you're fixing for them. All right. And respiratory rates, ominous, all right? That's the first time I've seen that come up here. Less than 8 per minute or greater than 30 per minute in adults is a sign of a serious issue, signify respiratory failure coming. So yeah, if you see someone breathing really slow or really fast, that is a bad sign. You think they need to be in the hospital immediately. Want to watch out for that. And normal is 12 to 20. All right, tachypnea and hyperventilation causes range from psychogenic to potentially lethal. So like we said, if you have someone breathing really fast, it's hard to tell what it's from. It could be a panic attack. Psychogenic just means like it's in your head, so it could be a panic attack, or it could be a potentially lethal pulmonary embolism. So it's difficult to tell. You don't want to count on anything. You just want to be cautious. This says that if it's psychogenic, it will eventually resolve. In my experience, they can pass out and then they'll kind of reset, or they'll kind of talk themselves down. But you can also see the other way where it says eventually compensatory mechanisms will be lost and sudden respiratory failure will happen. So people can only breathe really fast or really slow for so long, and eventually you'll have a problem. And that is why these are all emergent issues. They all get ALS immediately because someone can't be breathing difficultly for that long. They'll eventually need to be intubated. They'll need medicine. They'll need something before they collapse. So always an emergency, always a time-sensitive issue. All right, this is hyperventilation. We were talking about that presentation of a sort of a panic attack. You have this like tingling sensation on your lips, hands, feet. And then you also have this cramping where your muscles kind of close up. So they may appear, hands and fingers are contorted, just means twisted up. So this is, although alarming, benign. This is a good way to identify a panic attack. If someone is breathing really fast, you can ask them like, do you feel tingling in your fingers and toes? And if they say yes, that's a good sign that they're having a panic attack. You don't want to not treat it as a serious complaint. But that can sort of help you think, okay, maybe this is a panic attack. And once you can coach them down, you just want to help them slow down their breathing. That will go away for them. If you can't help them slow down their breathing, you might have a more serious issue. All right, breath sounds, listening with a stethoscope, which we have up there in the first aid room, or you can get your own stethoscope. Normal breath sounds and abnormal breath sounds are something that you kind of have to hear. If you'd like, you can go on YouTube later and they just have examples of breath sounds. Like Liz was saying, these do have pretty characteristic sounds. How I learned them was just listening to YouTube videos. You can look up wheezing breath sounds, crackles, gurgles, and you can hear what they sound like through a stethoscope, or even outside the body. There's like a wealth of medical knowledge, even on YouTube. So it's something that comes with experience, but if you want to go look with it, you can just go look on YouTube and get some examples so you can kind of see what they sound like. You don't need to fully learn them. It's really, like we said, the scope for an OEC tech is you need oxygen, you need an ambulance, and we're going to get you those two things as quickly as possible. And then the diagnosis of like, oh, what type of breath sound is this? That's less important. If you get comfortable and you want to move up to kind of informing your care with like, oh, this sounds more like this sounds more like this, that's up to you. I would just make sure you have the basics before you go and do anything like that. Make sure you're comfortable with the basic triage and care of these patients. All right. And if you listen with a stethoscope, always tell the patients, why do you have to do that? Before you do any physical exam, what do you have to do for a patient?
Permission to touch them.
Yes, you have to get consent, or else you are technically committing what?
Battery.
Battery, exactly. So you have to get consent from a patient, or else you're technically committing battery. So that can just come as like, hey, I'm going to listen to your lungs, okay? And they'll be like, okay. It doesn't need to be really formal, but just give them some warning. And then have them sit up and, just listen on the back, on the chest.
And make sure the stethoscope's warm or you will be battered.
That is fair. And that says that right here, actually. Avoid startling a patient with a cold stethoscope. That's a great
Nothing
point.
worse than a cold stethoscope.
Yeah, that's not pleasant. So unless you're trying to wake someone up, maybe they've had too much to drink, and then you just slap that right on them and hey, they're awake. All right, so instruct patient to breathe normally, and just have them, take a deep breath. Same thing doctors do to all of us. Just have the patient take deep breaths. These are your points for listening. These are just meant to help you listen to every lobe of the lung. The lungs each have multiple lobes or multiple sections to them. And if you listen at 2 points on the chest, 2 points on the back, 1 upper, 1 lower, it's going to be hard to miss any issues. So you're just going for sort of this broad coverage.
The objective 13-3 reference.
Sorry.
You're fine. So if you're going to listen, just make sure you do both sides, front and back, upper and lower. And that's just going to make sure that if there is a defect somewhere in the lungs, you'll probably hear it, you won't miss it. If you just listen to the top, you might miss something at the bottom, and vice versa. All right, pulse ox, we do have these on the mountain. These are a great tool. They're not incredibly accurate, but they can give you a sense of how emergent someone's issue is. But you also want to, as a general rule in medicine, you want to treat a patient, you don't want to treat numbers. So if someone looks like they're having a lot of trouble breathing, you're not going to say like, I might give you oxygen. Let me just check what the pulse ox has to say first. Like, just give them oxygen. So the pulse ox is good for vital signs. It's good for reports. It can add a little extra color and detail. But really in these emergent issues, if you think someone's having difficulty breathing and they need oxygen, just give them oxygen. The pulse ox does not need to come into play. If you have time and you're in the first aid room and you want to add it to your vital set, you can do that. But it doesn't need to show that your oxygen's low before you give oxygen. That should really be based on what you're seeing in the patient in front of you. That's just a general rule for medicine. All right. And here, yeah, the degree of dyspnea perceived by the patient or how hard their breathing is may not correlate with the pulse oximeter. So it helps you decide what to do with oxygen, but treat according to what the patient shows you right here. So yeah, definitely pulse ox is helpful. It's not the end all be all. What is the final say is, what does this patient look like? What do I feel like they need? You're treating the patient, not their vital signs. All right. Treatment of respiratory emergencies. So we definitely said this centers on improving oxygenation. So we want to address any issues with the airway we can. Is it open? Is it clear? Treat the pulse. So you want to go through your ABCs, see if circulation is contributing to this issue. If a patient is choking, of course, you want to go down that algorithm. We haven't gone through this before, I don't think. If someone is choking and they can still speak or they can still cough, the best thing to do is actually just let them cough that thing out. You don't need to get in there and start doing the Heimlich. It's actually better to just let the patient cough it up. If the patient cannot speak, then you do the Heimlich. If they can't move any air, that's when you do the Heimlich. Okay, we talked about the Heimlich and abdominal thrusts. All right, if the patient is responsive and there's no indication for spinal injury, You can put them in a position that maximizes comfort. So for most, this will be the tripod position. We practice that. You can help them sit up and say, hey, lean forward. I'm going to help you sit up and lean forward. It's going to help you breathe. You can do that to treat someone as well as using it as a symptom. Do not put the patient supine. That's not a comfortable way to breathe. What you can do is if someone's on a stretcher, you can sit them up. We have a stretcher in the first aid room. We have little tables. You can help them sit up on the table. That will help them breathe. Position helps a lot. All right, trouble breathing and no shock. Load the patient into the toboggan with the head uphill. This elevates the chest, so you can help them sit up a little. You can raise the head of a backboard. Always give supplemental oxygen. All right, so let's ask a question. If you have trouble breathing, but you're not in shock, why would you put the patient's head uphill? And if someone is in shock, conversely, you want to put their head downhill. So what is the reason for that change in management? What's the plus of putting someone's head uphill? And what's the plus of putting someone's head downhill? There's goods and bads to both sides.
For the first one is easier to breathe, and for the second one, it's blood flow to the brain.
Good. Yep, so the second one is self-explanatory. You put someone's head downhill, all the blood will go to their brain. And if they're in shock, the primary thing you're worried about is getting enough blood to the brain so that they don't have severe brain damage in the long term. So head goes downhill, blood to the brain. If the head is uphill, why does that make it easier for you to breathe?
All the abdominal contents aren't pushing against the abdomen and diaphragm.
Yeah, perfect. So that helps because it kind of frees up the abdomen. It kind of takes the pressure off of that diaphragm with the abdomen. That's also what the tripod position does. If you sit up like this, you're kind of pulling the diaphragm away from all your abdominal components. So it also frees up room for you. So good. Yeah, it's just physical, like pushing on the diaphragm.
So if they've had head trauma though, would we go with the uphill opposed to downhill just for the pressure in the brain?
That's, God, I mean, if someone has head trauma on the hill, I don't know if we'll get into that.
I'm just kind of
that
one.
That, I mean, balancing that, I honestly don't know what call I would make. I would probably just go with, do they really look like they need help getting their brain perfused, or do they really look like they need help getting oxygen? I think that's a hard, it's a hard call to make because we'll get into trauma, and you're right. Like if someone has head trauma, there's specific ways to load them in the sled. You don't want to increase their ICP too much, but you also don't want them to not get their brain perfused. That's a difficult call. Yeah. Okay. So we'll go into that more in trauma. Honestly, who you should ask about that is Captain Rizzo, if he's ever on. He would probably have better knowledge on something that detailed. I couldn't make a call on that. I don't know.
Okay, I'll look out for him.
Sure. All right. So high flow oxygen, always giving oxygen to these breathing difficulties. What is the important thing to do in before you give this oxygen? You always have to do one thing with this mask. What is the one thing you have to do before you give this mask to a patient?
Blow in it. Put air in it.
Fill in the bag.
Yes, you do not blow in it because that would contaminate the bag, but you do inflate the bag by putting your finger over the little hole that blows it up. Now it's going to work. Good. All right. Most of the time, high flow oxygen by non-rebreather. They're saying most of the time we use this, which is true. On the mountain, we use this. We also have nasal cannulas. Those are going to be our two oxygen delivery methods up there. As a delivery or as a rule, you start high and you go low. So you just, it's a breathing issue. It's something you want to fix fast. So you don't mess around. Just start them on high flow oxygen. That's like non-rebreather with 15 liters per minute, your max setting on the non-rebreather. If someone has severe difficulty breathing, just max oxygen. If they get much better, you can say, okay, maybe we can take this down. You can start to decrease it. But just in the interest of fixing these things quickly, you don't want to mess around. You want to fix it quickly. Just give high flow oxygen maximum immediately. All right. And if you need to, if that doesn't help them, if you give high flow oxygen and they're still not looking good, then you might want to move to positive pressure ventilations, like actually helping them breathe with the bag valve mask. That's your next step up. All right, refusal of face masks is common. People don't like the face mask. It feels claustrophobic. It's like, why is this thing on my face? Even though it's giving you oxygen, people often feel like they can't breathe with it on. So usually you can encourage them and kind of just talk them down and say, hey, like, I know it feels weird. Just give it a second. It's dumping oxygen in. Try and feel that. Try and take a breath. You'll feel better. That will often work. If it really doesn't work, you can switch to the nasal cannula, which is the one that just goes in the nose. And that's better than nothing at all. All right, using an inhaler. So if someone has an inhaler, use it. Oops. It's basically as easy as that. People know how to use their inhalers. So if someone is having an asthma attack and they just need their inhaler, get it for them, help them use it. They will hopefully get better. It's about that simple. You are allowed to do that. You are allowed to help people use their own inhalers. All right. Yep, you can help them use their own inhaler. Do not use someone else's inhaler. This is what Dean brought up. Like I said, we are not allowed to recommend this. In fact, we are not allowed to recommend any medications. We're OEC techs. We cannot prescribe medications. So even if someone asks you like, hey, I hit my head, or not, that's not a good one. I hurt my wrist and like, I think I should take some ibuprofen. Do you think it's a good idea to take ibuprofen? You technically should not make any medication recommendations to these people. Because that's outside of our scope of practice. The only medicine we deal with is oxygen. So if someone has like, they're like, oh, I have asthma and my friend uses the same inhaler that I do and I forgot to bring mine, but my friend has theirs, can I just use theirs? You want to be very careful because you're putting yourself in kind of this legally compromising position. That's not something you can legally recommend to this patient. You can't say like, oh yeah, you should totally, I'm recommending as a medical professional that you take your friend's inhaler and you use it. At the same time, if this person is having an asthma attack and they do know that their friend has the same inhaler that they do, maybe they should use their friend's inhaler. But you can't explicitly say, yes, I recommend that you go do that from a medical standpoint. So with these people who are asking for medication advice, I think a safe thing to say is, I can't advise you on medication use because at my level, I don't deal with medications. But if you think that's something that will help you, you are free to try it. Of course, if they're suggesting something that you think is dangerous, you should probably tell them that. But if you think they're suggesting something that's reasonable, but you just can't legally endorse it, then that's a safe thing to say is you say, hey, I can't advise you on medications. That's not my job. That's not my scope of practice. But if you think it will help you, you're welcome to try that. And what I can do for you is I can give you oxygen. I can call you an ambulance. That's like a safe way to deal with someone trying to do something like that. You just want to be careful for legal reasons to not make any weird recommendations to people. All right, case study. Middle-aged man walks in the parole room saying, I can't breathe. You immediately have the man sit down and begin your assessment. During your questioning, you find he is a smoker. And 3 weeks ago, he had minor knee surgery on his right leg. He said this is the first time out skiing since surgery. He is breathing at 28 breaths per minute and appears in distress. He has mild chest pain and cannot talk in complete sentences. His right calf is swollen and tender. What should you do? Who wants to approach this?
Call ALS.
Good answer. That is a great first thing to do. Because this seems pretty serious, right? So as soon as someone walks in, you want to get the ball rolling, get the ambulance on its way, call ALS immediately. Perfect. What do you want to do next?
By oxygen.
Oxygen, great, because we almost jumped one step though. What do you do? That's technically you're addressing their breathing. What is one thing you can check before you address breathing?
Airway.
Airway, good. So if this person walks in and they're ambulatory, they're walking up to you and they are able to speak and say, I can't breathe, what does that say about their airway?
That it is patent.
Good. So their airway is patent. They're able to speak. They're able to walk to you. They probably don't have something lodged in there. So airway is open. You can move on to breathing. Oxygen is a great idea. Let's get you some oxygen. What's next?
Circulation.
Circulation, perfect. So this could maybe be a cardiac issue. They say they have chest pain. Any shortness of breath should be treated as a possible cardiac issue. So check their circulation. So we'll check a pulse. All right, anything else? What else do we want to check?
We could ask his history.
Good.
That's new.
Good. So it sounds like he had minor knee surgery. You could get a more complete history. Like, do you have any difficulty breathing usually? Do you have any illness that would cause that? Do you take any medications? Are you allergic to anything? All right, good. That's pretty comprehensive. So you place the pulse ox on his finger, which shows a pulse of 120. This is a good, I didn't cover this, but the pulse oxes are helpful in that they will give you a pulse. So even if the oxygen sat is not always reliable, the pulse is. And so that it's a great tool for that. Instead of having to like count someone's pulse, this is much more convenient. And an oxygen saturation of 85, which is not great. He becomes more anxious and his respiratory rate is now 28 breaths per minute. Since he has chest pain and a low oxygen sat with obvious respiratory distress, you place him on high flow oxygen, great. The non-breather, and have another patroller immediately call for transport. Great, you guys all covered all of that. Your sample history only reveals recent knee surgery. Again, you covered the sample, good job. While waiting for transport, you consider the possibilities of MI, heart attack, pulmonary embolus from the blood clot, or other causes of acute breathing problems with chest pain. No matter what the medical problem is, transport is urgently needed. Theme of today. So these can help people down the chain. Things like, you had knee surgery recently, your leg was immobilized for like a week, maybe you have a blood clot. Like that can help the paramedics manage this patient. But the big priority is going to just be the treatment and the transport. So how do you give a report to the pre-hospital ambulance personnel when they arrive? Who wants to try that? So you're looking for, remember when we give a report, we talked about this last time, you want to just give a concise, like you want it to be relatively efficient, but also comprehensive. So it's really a difficult thing to do well. You want to cover everything that should be included, and you want to trim as much fat as possible. So you're just trying to mention everything you think is important and not leave anything out. So what do you think is important about this patient? Like when you hand them off to the ambulance crew, what would you make sure to tell them because you think it's important? Let's get one person to give a report. Let's see. All right, Razvan, I think you started there. Oh, Kelly, you want to go?
Sure.
Go
Okay,
ahead.
I'm probably gonna just.
No, please.
Anyways, maybe you tell him about that he's got 85% oxygen saturation.
Okay.
He's anxious. His respiratory rate is going down. I find myself wanting to, like, instead of like helping, I find that I want to, like, my brain wants to like try and figure out what he has.
Yeah.
I don't know. Sorry. So.
No, that's fair. I think we all like to solve puzzles, but you want to focus on treatment. I think you recognize, that, but yeah, it can be interesting too. Maybe later after you can really dig into it.
I would add probably a rapid pulse to the overall image and a history of a recent history of knee surgery.
Good. Okay. So I'll actually.
Yeah, chest pain, I think it's also important.
Chest pain, absolutely. So you guys are hitting the right notes. Like you're definitely including the right pertinent positive stuff. I think maybe I didn't give you enough like scaffolding to kind of put your report together. But generally, the way you kind of want to run a report is you want it to have a flow, and to make that easy, there's a really common thing in medicine called a SOAP format, SOAP. And it just means subjective information, objective information, assessment, like what do you think is going on, and then the plan, like what did you do? And so for a patient like this, what that looks like is basically just say what happened, what did the patient tell you? So you say, oh, okay, so this is a whatever-year-old male. He walked into the first aid room. He said, I can't breathe. He told me that he was having chest pain. He told me that he had recent knee surgery. and that he also has no medical illnesses. So you're giving a quick, like, what did the patient tell you? What like symptoms did he bring up? What medical history did he tell you? The subjective stuff, everything that was reported to you. After that, you go into the objective stuff, and objective stuff is stuff that you see yourself. So then you're talking like vital signs and physical exam findings. So after you say kind of what happened, you're like, yes, this guy came in, he said he can't breathe, he said he has chest pain, he said he had recent knee surgery, no other history of illness. Then you move into your objective, your vital signs. You're like, I checked his vital signs, he had a pulse of 120, his oxygen saturation was 85, he's breathing 28 breaths per minute, shallow. And then I also noticed that his calf was swollen when I squeezed it. And so I think he might have an MI, he might have a DVT. What I did was I gave him oxygen and I packaged him for transport. So you're following this flow of like, you say everything the patient told you. So their symptoms, their history. Then you go into your exam findings, your vitals, and then you go into your treatments and what you think that might be going on with them. So we'll practice that more, but that's a really easy, broad way to organize it. It's SOAP, S-O-A-P. I would write that down if you haven't. That's going to be how like a really easy way to organize a medical report. So subjective, objective, assessment, and plan.
I think we went over that with Rizzo.
Okay, great. Perfect. So yeah, that keep using that because it just makes it a really easy, again, if you do things the same way every time, you get better and better at it. So keep using that.
What did A stand for again? I'm sorry.
Assessment. And then P is plan. So your assessment is basically what you think might be going on with them and what you based your plan on. So in this person, you're like, I think he might have a heart attack. I think he might have a pulmonary embolus. And then you move on to your plan and say, in light of that, to cover both of those, I gave him oxygen and I called him an ALS unit right away. So assessment and plan are tied together. It's like, what's going on and what did you do for it? All right, good. So you titrate their O2 sat up to 94 or better. Continue to take vitals every 5 minutes, allowing the patient to sit up. Ambulance personnel arrive. You explain the patient had significant dyspnea and chest pain. He has been on oxygen with an O2 sat of 94. You show the vital signs indicating respirations and tachycardia, and the knee had knee arthroscopy 2 weeks ago. Showing the swollen, painful cast to the paramedic, you both consider the possibility of a pulmonary embolus. Following rapid transport, further tests are completed, showing a blood clot. He is given medication and recovers. All right, and then he comes back 3 weeks later to thank you. How nice. All right, happy ending. So yeah, you can see they kind of organized it in the SOAP format. They give you, they say the ambulance personnel arrive, you explain significant dyspnea and chest pain, what he reported. Then you move on to more objective vitals. So you're saying the vital signs, respirations, tachycardia. You talk about the physical exam, the swollen calf, and then you move on from there to the diagnosis of pulmonary embolus and what you're doing for it, the transport. So it's subjective, objective, assessment, and then plan. All right, skill activities, just listening to lungs. We'll practice this in person. We showed you the spots that you can listen front and back. You can also do side here if that's easier, just by positioning. And then of course the, oh, this is actually not for oxygen, it's for the inhaler. Ensure that it's the correct medication for the correct patient. That's a good rule for all medication administration. You always say like, okay, double check. Is this what I'm meaning to give this person? Yes, it is. Here you go. And then honestly, they make a big deal out of helping someone use their own inhaler. But I mean, if someone has asthma and they use their inhaler a few times a week, do you think they'll know how to use their inhaler?
They'll know better than you for sure.
Yeah, exactly. So like you can be like this if you really want to, but you can probably just give it to them and they'll use it. Unless they're like really struggling. If they're really struggling, maybe you help them, but they'll probably know what to do. All right, and then reapply oxygen. Very good. So that's it for that one. We are gonna bust through allergies in like 20 minutes, and then I'll give you all a break, and then we can do the review session. We can do allergies real quick. Unless y'all need like a break now. Do y'all want to bust through for like 20 minutes, or do you want to take a break now? We'll leave it up to the group.
Roll it. So.
Let's go. All right, easy enough. Allergic emergencies, that's what we're covering. Just another type of respiratory emergency. All the same rules apply, except there's going to be just this extra added. If you can identify an allergic emergency, you have like one other thing available to you, which is the EpiPen that you might be able to use. So there is utility in determining someone's having an allergic reaction. You might be able to fix it for them with an EpiPen. So allergies and anaphylaxis. Anaphylaxis is just a word that means a severe allergic attack. Causes airway swelling, causes difficulty breathing. All right, so we're going to list ways an allergen can enter the body, list potential allergies, signs and symptoms so you can identify it. That's the important part. And then what do we do with an EpiPen to fix this? All right, so many people have allergies. I'm sure a lot of us have allergies. I have seasonal allergies. You might be allergic to peanuts or something. We all know what allergies are. They can be more than a simple nuisance though. You can have severe reactions to food allergies or other things, and they can be deadly. So I'm sure we've heard of this too. Deadly peanut allergies, bee stings, a lot of things can cause really life-threatening allergies. All right. So simple runs from like hay fever. I'm sure a lot of us have had hay fever. You know, there's pollen in the air, you have a runny nose, your chest might get a little tight, but it can also go all the way up to life-threatening shock through the same pathway. It's the same pathway, it's just more or less severe. It can get much, much worse. So you just want to recognize the signs and symptoms and be ready to jump on that and say, this is an allergic reaction, we need to treat it as such. Do you have an allergy? Do you have an EpiPen? Because a lot of the time these people know they have an allergy, which means they carry an EpiPen. The family might have an EpiPen. So this is something you can address. Otherwise, if they don't have it, then ALS will carry that epinephrine with them and they can give it as soon as they get there. If you've identified that it is an allergic reaction, you can actually have that called in and they can be totally ready to go and they can give it IV as soon as they get there. So identifying an allergy attack is it's a little bit better than the other ones where like, okay, is this P or MI? I don't know, I'm just gonna give you oxygen. If you can identify an allergic attack, that can actually change the management quite a good deal. So this is a good one to kind of learn about and be able to pick out. All right, so correct and timely response can lessen the overall effects of the reaction. Of course, you can abort it early on. All right. Everyone's favorite, the dry stuff, the anatomy and physiology. The immune system protects the body. Cool, we know that. Chief parts of the immune system are listed here. We covered these early on. Without the immune system, we would die. That's pretty self-explanatory. Basically what this is getting at is when something gets into the body, the immune system will react to it with antibodies, which are going to destroy it. They mobilize the immune system, triggers a chain of events that cause this reaction. What happens with allergies is you have a reaction to something that you really shouldn't. So it's a hypersensitivity. And now where the body should be responding to like a virus or a bacteria with like a low level response, for some reason, the body just goes wild, it goes haywire, and it responds to something as benign as a peanut, as if it's going to kill you, and then it mobilizes this huge immune response. And it's actually your body's response to that substance being inside of it that causes all these problems. It's like a way too far immune response that causes the difficulty breathing, the throat swelling, the blood pressure drops. All of it is caused by your own body's immune system in reaction to these things. And when this happens, this severe immune reaction on the part of your body, we call that anaphylaxis. So this just means a severe allergic reaction, and it is life-threatening. All right, anything that triggers allergies is known as an allergen. You can eat them, you can inhale them, they can be injected like a vaccine people are allergic to sometimes, or you can touch them like, I don't know, people are allergic to latex. Basically any way you can contact something, you can be allergic to it. All right, once you are exposed, repeated exposure will cause an allergic reaction. A lot of people get sensitized to bee stings and then they get a bee sting later in life and now they're allergic, they have serious problems. Histamine is the chemical that causes a lot of this. It's what's released from the immune system when an allergen enters the body. That is why antihistamines like Benadryl are what you use for allergies. So an antihistamine blocks the release of this chemical histamine that kind of tamps down the body's allergy response. All right, common causes. So they can be chronic throughout the year, or they can be immediate, like kind of a one-time thing, like nuts, soy milk. We all know what allergies are. Insect bites, environmental irritants, pollen, mold. Animals, medications, chemicals, other things here, organ transplants, blood transfusions. You can be allergic to plenty of stuff. All right, peanuts are the #1 allergic food. Exact reason unknown. Children more prone. Also, dust mites, okay. Chemicals like latex, rubber. Stress can also worsen allergies. Great. All right, so this is the important stuff, is like, how bad is this? Do you need a severe intervention, or is this going to get better with some Benadryl? So a mild allergic reaction is you might see some urticaria, which is hives basically. When you see like little pink kind of raised patches on your skin, you can call those hives. The more medical word would be urticaria. Hives is fine though. And then if you have your skin gets kind of flushed and pale and really itchy, we call that pruritus. It just means itching. You can have kind of tingling, you can have runny nose, watery eyes, kind of feeling tired. So this is almost hay fever. If you get like a little rash and itchiness, I'd say it goes a little bit beyond hay fever. Like maybe this is coming in contact with a cat when you're like pretty allergic to cats. It's not life-threatening, but you want to be careful. Anyone who gets systemic symptoms of allergies, that's kind of a red flag. So if you see like a rash on someone's chest, if their whole body is itchy, I would be very careful with that, with just saying like, oh, this is mild, you seem okay. These can always get worse. And anything that is systemic is worrying, okay? So like runny nose, that's fine. If your eyes are itchy, that's fine. But if you have like a rash that's on multiple parts of your body, if multiple parts of your body are itching, that's a bad sign. It means it's spreading. So they can develop over minutes, hours, or days. So you want to be careful. Like this can get worse. You want to be careful about dismissing this. And you might help telling people that. That's a pretty impressive picture. This is moderate allergic reaction. This is called angioedema. It just means that a layer of tissue is swelling. Often you see this in the face. The tongue will swell. The airway can swell. This is where you get life-threatening issues. So you can have hives on your chest and arms, like I was saying. You have itching. The skin is pale. And now you're going to start to see swelling of your airway and swelling of your tongue. This is when it's life-threatening. It needs to be addressed. Okay, so breathing may become compromised. Your bronchioles can close up. Wheezing can be present. Like Liz was saying, you might hear these people wheezing. It might be bad enough that you hear it without a stethoscope. So if someone has an allergic reaction, they say, oh, I'm allergic to peanuts. I think I might have had some peanuts. And you can hear some weird noise coming out of their airway. That's a sign that the peanuts are now affecting their airway. That's a bad sign. That means that's progressed pretty far. That's an emergency. So as breathing becomes compromised, the amount of oxygen reaching the brain may be reduced, of course. We need to breathe. All right. GI distress is common. Yeah, so people might get, allergies can manifest in different ways. You might get nausea, vomiting, diarrhea, heartburn. So not a reason to write this off and say like, oh, you ate peanuts and now you're like vomiting. Well, that doesn't sound like an allergic reaction. That could be an allergic reaction. That's actually pretty common. So it's not always just airway. It's not just the itching and your throat closes up. You can also have your stomach gets irritated because it doesn't like the peanuts either. Okay, so they may appear in a few minutes or a few hours. They may go away. They may get much worse. So allergies are tricky. It's kind of the case with a lot of medical issues like difficulty breathing, allergies. You just want to be cautious. You say, I don't know how this is going to turn out moving forward, so I'm going to assume that it's going to get worse, and I'm going to act accordingly. All right, severe allergic reactions, anaphylaxis, a massive amount of histamine affects your lungs, it affects your skin, it affects your blood vessels, it affects your stomach, it affects everything. Okay, so one of the big things this will do is constrict your bronchioles, which makes wheezing really apparent. So you'll be able to hear these people wheezing often without a stethoscope. And that will make it difficult to breathe. So you may have to give these people oxygen as well as an EpiPen. Angioedema is swelling of the tongue and lips. What do these people need? If they have angioedema, what's the only thing that is really going to help them in terms of keeping their airway open? What do they need?
NPA, I guess.
So angioedema, that's a good thought. Angioedema includes not just the tongue, but also the tissue of the throat, the tissue of even the larynx sometimes. So an NPA would not even fix this. An NPA could move the tongue, but you could still have swelling of the throat tissues past the NPA, and it would not work in this case. So what's a higher level intervention that we might not, well, we won't be able to give? What would these people need?
Intubation.
An EpiPen? What? Intubation.
Yeah, it would be intubation. So these people, if you have angioedema, you're going to maybe be intubated. Like you would try to treat it with medication, but really the only way to protect their airway from this swelling is going to be to put that intubation tube down there before the swelling gets so bad that you can't even pass a tube. So
Can I show
these
you a
people,
picture of what that would look like, guys?
yeah, Liz, let's see. Is this from your experience?
This was when I was intubated due to allergic reaction to Benadryl.
That's rough. Here, let me make you the host or
Oh, you don't have to.
co-host.
I don't know how to. I'm just holding up my camera, so you can't.
Oh yeah, cool. Let's see.
I don't know if you can see it.
Oh dang,
I
yeah.
see it.
A good amount of swelling.
There's the ventilator there on the side.
Yeah.
But that was about 35 to 40 minutes after they turned off my sedation after the intubation. But I don't talk normal anymore because of it. It damaged my vocal cords. It was an emergent one. So, but something as simple as Benadryl. So, yeah.
Benadryl was supposed to fix the problem. Not to
That's what is the common thought. Yeah, that's not what fixed my problem at all.
Wow.
Yeah. It's the dye in Benadryl people are commonly allergic to. You'd think they could take the dye out, but I guess not. They want to sell that pink Benadryl. Yeah. But you can, so like Liz, that's a great example. That's the only way often to protect these people's airway. And so the reason I bring that up is because that's just, they need an ambulance. So like, even if it's not bad now, it might get so bad that their airway swells up and you can no longer intubate that person. So they need to be with someone who is able to intubate them as soon as possible so that you don't miss that opportunity. And just in case their airway continues to swell, it can always get worse. They might need to be intubated preemptively. And so this is always ALS. If you see any sort of swelling in the face, or they say, I feel like my tongue is swelling, I feel like my throat is swelling up, that's always ALS. They need to be with someone who can intubate them if they have to. And that is a great example to drive it home, Liz. I hope that sticks with us now. All right. So effects are often obvious. Usually if someone has a severe allergy, like Liz said, it only took a few minutes to develop. That's usually the case. And so again, very time sensitive. Think you're working with very short time windows. So if someone says, I ate some peanuts and like, I think I feel my throat swelling up, then be cautious and say, it's possible your throat is swelling. It's possible it's going to be much worse in 5 minutes. I'm going to call ALS now. So always be very cautious with this. All right. And then serious medical condition if this progresses to shock, because you can also have the blood pressure fall for chemical reasons. That histamine can make your blood pressure drop to dangerous levels, and that will make it difficult to get enough oxygen.
So, Greg, I have a question.
Yeah, please.
The ALS takes 45 minutes to get to the hill. How do you treat these potentially very severe cases?
That's a great question.
Shock or whatever.
What you would hope is that Mount Charleston Fire is closer. Often it takes 45 minutes for a transporting unit to get from the valley to the resort. But Mount Charleston fires should usually be within like 10 minutes of the resort, and they can usually do it. If not, you could try NPAs, you could try OPAs. I don't know what kind of results you're going to get with those. You would be in a very difficult position if someone had this going on and you did not have ALS to provide an airway intervention. What I might suggest at that point is we'll get to treatments, probably an EpiPen. And this is a situation where I've had EMS providers tell me this as well. We'll get to it actually, EpiPens. We'll talk about it in a minute. I mean, that's going to be your main thing. If you're far from an airway intervention, you can fix this with epinephrine, and you just want to get it to them as soon as possible. And we'll go over the treatment in a minute here.
So that's like an exception from the general rule of not using medication.
Yeah, I mean, it's not an exception.
I don't know.
Rule.
It's pretty.
Yeah, I mean, I'll tell you now. We'll get into it now.
Yeah.
If someone else, so an EpiPen is the cure for an anaphylactic reaction. So if you have a person in front of you and their throat is closing up and you know that ALS is 15 minutes away with their epinephrine, and someone else comes out of the cafeteria and they're like, I recognize this person's having an allergic reaction, take my EpiPen and use it. Like, that's technically illegal because you're technically working outside of your scope. And so I would not tell you to go and do something that's illegal, right? But I also wouldn't tell you to just watch someone not breathe while you have a perfectly good EpiPen that is usable, you know?
I mean, the person might die in front of you. That's the reality.
Yeah, exactly. So,
I mean,
you're in a gray area.
Point.
And I doubt anyone is going to take legal action against you if you use someone else's EpiPen to save their life. You do have to keep in mind that, like, we don't have extensive knowledge of medications. There's always the possibility that if you go outside of your scope, you make a mistake. And if you make a mistake outside of your scope, that's gross negligence. And that is very legally actionable. So that's why, like, no instructor would ever recommend that you do something like that. I'm just saying that would be a very difficult position to be in. And that could be a situation where you say to the family, like, hey, I can't do this legally, but if you want to take that EpiPen from that stranger and use it on your family member, you go ahead and do that. It's a difficult situation. You're in a gray area legally, so it's up to you how you want to handle that. But I mean, I wouldn't just let that person die. Like, you have a medicine that can help them. It's up to you how you handle that. I would say that would probably be your best bet if there is no ALS coming and this person's throat is closing. You need to do something. And odds are, in a resort of like 400 people, maybe someone has an EpiPen. You could go and look for someone else's EpiPen. You could.
Hey, Greg, I actually have a quick question for you.
Yeah.
Just kind of to further what he just asked, is there a insurance policy or something that either the mountain or the patrol or we individually can carry in case of a bizarre situation like that to remove whatever liability from ourselves?
That's a great question. And I would say it's a rule in medicine. You can never remove all liability from yourself because you never know what someone's going to go after you for. But what the mountain will do is they will defend you as long as you're working within your scope. And that's why I'm talking about scope. And what makes this difficult is because we have a set out rule. We have a set of protocols that says, in this situation, you are authorized to do this. And a doctor wrote out these protocols and he signed it and said, this is reasonable. And as long as you're within those protocols, if anything happens and you only did that, then the mountain will be behind you. And they'll say, look, like, we have a medical director, we have a doctor who said, in this situation, you do this. And this patroller did exactly what that doctor said. They acted in good faith and they acted reasonably. That's protection. That's your insurance policy. You'll have the resort behind you if you acted reasonably and something happens, someone tries to sue you. The problem is medications are not included in our scope. That's what I'm getting at, is that as soon as you make a medical recommendation to someone, the doctor never ordered that. The patrol does not have protocols about that. So you should not be doing that. It puts you in this area where now if you are a medical provider and you act outside of your scope and then something goes wrong, that's technically something called gross negligence. It means that you did something dangerous by going outside of your level of training and you caused harm to a patient. And so you would be uncovered legally. You would not have any legal recourse if someone, like, say the EpiPen was expired and you said, yeah, like, this person needs an EpiPen, give me that EpiPen, and you administer it to the patient and you actually make things worse because the EpiPen was expired, or maybe it wasn't even the right medication, it wasn't an EpiPen and you just made a mistake and it was something else like glucagon and you gave it anyway, then you're outside of your scope because you're administering a medication. You made a mistake and you hurt a patient. That's gross negligence. So that's what I'm saying. It's a very difficult situation for you to be in because you're risking yourself there.
Greg, let me ask you another question.
Yeah, sure.
Would this be something that would be covered under the Good Samaritan law? If you, outside of the scope of your training and responsibility, you choose to give like a patient an EpiPen.
Yeah, no. So this, like you said, the key word there is it's in the scope of your training. So this is not in the scope of our training. That's why I'm telling you that the safest thing to do here, whenever a patient like needs an emergent medicine, like an inhaler or an EpiPen, that another patron comes up and says, oh, I have that, I can give it to them. What you want to do in that situation is, like, if you think it's the right thing to do and you think it's the only way to save that person's life, then obviously you have to take that as your course of action, or I would assume you want to do that. But you have to make it clear that you are not the one giving it. You are not the one recommending it. You're just saying, yeah, if you guys want to do that, that sounds reasonable. And if you think it'll help, then you can do that. If you kind of step back and you don't actually put yourself into it, that's the safest thing for you to do legally, because then you're not acting outside your scope. Then all you did was you watched one stranger give their medicine to another stranger and you just stood there and you watched that. You didn't do anything. So you're not legally liable for anything. But if you get to the point where you take it and you give it to the patron, then you're legally liable because you administered it.
But let me make sure I got it right. So the second person who's giving the EpiPen would be covered under the Good Samaritan law. Mm-hmm. However, you would not be in this particular scenario.
I don't know if the Good Samaritan law would extend to them. Honestly.
Or would they be liable as well if they make a mistake?
I think you could make the argument that, well, first of all, if that person came up and without the patient's consent or request just said, I have an EpiPen, I'm going to give it to you, and they inject a drug into someone and it causes an adverse effect, they absolutely are liable. That's like battery and poisoning. I mean, that's not okay. But if you have a mutual exchange where this person is having an allergic reaction and someone else comes up and says, I have an EpiPen, do you want it? And the person having the allergic reaction says, yes, give me the EpiPen, then it's not even like this person's not giving medical care. They just gave this person a medicine that they requested, and this person administered it to themselves. So it's like, that's not super medical.
Yeah, but how about if the patient is in such a dire state that you have to imply consent? You cannot get a consent from the person.
Man, honestly,
it's getting very gray area. But
it's a lot of medicine you can run into these areas, and I'm not trying to tell you guys to do anything or to not do anything. I just want you to think like it's up to you how much you want to risk your own position and possibly legal recourse, and what the cost of not risking that is. And if I were in that position, I mean, I'd probably just give them the EpiPen. Like, I'm not telling you guys to do that.
No, absolutely.
If someone's going to die unless you give them an EpiPen and you say, I might get sued, but this person might die, like, I'll probably, it's up to you what you do. But yeah, it sounds like you guys understand how gray it is and all the things going into consideration. So just don't implicate yourself. Don't go outside of your scope if you can help it. If someone asks you about medicine, the best thing to do is just say like, hey, like, that might help you. If you want to do that, you can, but I'm not going to recommend it. That will keep you kind of legally detached from that situation.
And I just want to add one quick thing. So probably the level of risk that you take goes hand in hand with your level of knowledge on certain issues. Like if you're damn sure that, that's the solution for the problem, then you might.
Yeah, absolutely. Yeah, no. So if you're at the OEC level, a doctor has written like protocols ahead of time. And if you only act under those protocols, then who is liable for that is technically the doctor who wrote the protocols. So yeah, that's why the protocols are great, and why adhering to them is important, is that you're just doing what you were told by this doctor, and it's on them what happens. You're working under their license. So that it is, depending on your level, we carry very little liability at the ground level as long as you follow the protocols.
So Greg, with getting ALS involved, if we know that this person is going to be more critical and we can see that this is happening faster, is it different, or how do they decide instead of an ambulance they want a helo over there, and who initiates that?
Yeah, so that would be it would be the patrol director who usually makes the call. You can, I mean, to actually launch the air ambulance, the patrol director is going to be on the phone with the air ambulance telling them what they've got. I would just encourage you to describe how your patient is, and it will be up to them ultimately. Like, you can say ALS transport for sure. If you feel like ALS is necessary, you can say start ALS transport for this patient. But if you think they need something like air ambulance, just describe their condition, like say severe head injury, actively vomiting, bleeding from the head, ANO 0, GCS of like 5. And if you say that to the patrol director, they're going to be like, I should get the air ambulance on this. It's just giving good information and a good picture is going to help them make that decision. And if you think it's necessary, like really necessary, you could suggest it. Just know that there's a pretty high bar for it.
Yeah, I was just wondering what that trigger was, and who it was that triggered that change in transport.
Yeah, it would be the patrol director usually, because they're the one who's going to call in. The dispatch is going to call in to either the ambulance company or the air ambulance. So you could, like, if you suggest it over the radio, it doesn't like automatically launch. Right. So if you think it's warranted, you can make the suggestion, and they might be like, I don't think so, or they might go ahead with it. But usually you won't have to do that, because usually they'll identify like, this is serious enough that we need air, and they'll call it in themselves.
Sure.
Yeah, good question.
Thanks.
Okay, so we got wrapped up in that. We're just doing scene safety. I think we got pretty well into the treatment of anaphylaxis emergency. So let's just run through this. We'll take a quick break and we'll do a half-hour review. So of course, this is just primary assessment for any injury. You want to do your scene safety, ABCs. We talked about how allergic reactions are evolving. They change over time. It may not be immediately apparent how bad it is, but it can always get worse. And then as a rule, those associated with respiratory impairment. So anyone who's having allergic reaction and their airway becomes involved, really bad sign. It can always get worse, and you don't want to be caught out if it does get worse. You can obtain a history if time permits. This is technically an ABCs issue. This is airway. So if someone has airway swelling, that's an airway issue. And if you have an ABC issue, what you want to do is correct it before moving on. So if you come up to someone and they say, my throat is swollen, and you go straight to, I want to fix that for you, you can kind of jump over the rest of the assessment and say, well, are you allergic to anything? Do you think you're having an allergic attack? If so, do you have an EpiPen? It is reasonable to go outside of our usual algorithm, because you're addressing an urgent complaint about airway. And you always want to fix, like if it's a breathing problem, you fix it right away with oxygen. If it's a circulation problem, you fix it right away with chest compressions. If it's an airway issue and their airway is swelling and you think you can fix that right away, you should fix it right away with an EpiPen. You don't have to go through the whole sample history, like, oh, have you ever had any surgeries? Like, if you're like, oh, you're allergic to peanuts and you might have eaten a peanut, let's do your EpiPen right now. That's probably the best thing to do in that situation. So good, you can ask if they've taken their medication. And then this is just identifying anaphylactic shock, signs of severe allergic reaction. So low blood pressure, fast respirations, fast heart rates. Sometimes there'll be alerts, but sometimes they'll be less than alert. It's a form of shock. So if you think that it's progressing this far, you also treat it as shock. That's the thing to focus on here, is that an allergic reaction can progress to being so severe that it is now shock, which means that your body is not getting enough blood circulating. That's the definition of shock. So it should be treated as such, which means you do the supine positioning, you do the blankets, you do the oxygen, you do the transport for any type of shock. And this can be a form of shock. So if you start to see those things like low blood pressure, decreased level of responsiveness, this has now become a shock issue and you treat it as such. Okay, here's management. True emergency, begin ABCD, open the airway. If the patient has an EpiPen, assist the patient as soon as possible by delivering a shot of epinephrine. So I just said that. Of course, if you kind of have to skip the algorithm, you kind of have to go outside of it to get to this point. So like if you're suspicious coming in, you're like, this person's in the cafeteria and they're just sitting at a table and for some reason they're really short of breath and they say their throat is swollen. That sounds like allergies. You want to go straight for that to try and fix it. You don't have to do the whole sample and everything. Just go straight to the issue, fix this right away. And then of course, whether or not you give them the epinephrine, give them oxygen. Even if you gave them the EpiPen and they think they're getting better, still give them oxygen because that can buy you some time. If they get worse, this will still help them having oxygen. If necessary, you can help them with ventilations and immediate transport. All right, remove anything around their throat. That sounds fair. Remove anything that might obstruct blood flow, of course. Position of comfort, typically seated forward. Remember, the tripod position is the best position to breathe in. So if you have someone leaning forward, that's going to help them breathe. And if allergic reaction is suspected, determine whether the patient has epinephrine. Do not use anyone else's epinephrine auto-injectors. So this is what we went over. That is the legal recommendation. But if ALS is 15 minutes away and some stranger has an EpiPen, all right, so contains epinephrine, promotes bronchodilation, it opens up the airways by putting that epinephrine in the lungs. What that does is open up airways. It will also correct some of the shock by correcting their blood pressure. They have a proper dose in them. An EpiPen is very easy to use. Maybe some of y'all have had training on it. All you have to do is shoot it in. You just make sure that you have the right end facing down, shoot it in, and just hold it there for 30 seconds. That's all you have to do. Super easy to use. All right, and then reassess every 5 minutes. Should rapidly improve. This is tricky though. So if a patient gets epinephrine, do you think they're totally out of the woods? Like, do you think they can just go on skiing for the rest of the day?
No, if you administer epi, they need to go to the emergency room.
Yes, so that is true. Why do we worry about them if they've just gotten epinephrine for allergies?
Because it's a short-term duration and they could continue to have a reaction later.
Yeah, exactly. So epinephrine can wear off and it's got a shorter action than the histamine, the substance that's making them have the allergic reaction. So they could actually get worse. They could get better for like 15 minutes and then they can start to get worse again as the epinephrine wears off. They still have that systemic allergic reaction. So even if they get the EpiPen and they're like, oh, I'm better now, I'm going to go back out and ski, they should still get transported by ALS and they should still go to the hospital as soon as possible so they can get more epinephrine and ride out this allergy attack. So it's not over. You need to keep them in medical care until you're sure that it's over or until a doctor clears them that it's over. We don't make that call. All right, and then because it is adrenaline, you can get anxious, you can get restless, you can get shaky when you give someone epinephrine. That is better than having your airway close up. All right, always call for ALS transport early. They need to go to the hospital, even if their condition improves. Oh, okay, great. Anyone who accidentally injects epinephrine into a thumb. So sometimes people have the injector upside down. They'll hit it into their leg, and instead of getting it in their leg, they'll actually put the needle through their thumb. They should technically, now they're a patient because they just poison themselves with medication. They should probably get medical care for that. And then you can still, yeah, actually, we'll leave it there. All right, good. Case study. I want to, rather than doing the case study, we can do it next time if y'all want. We're running short on time and we want time for review. Any questions y'all have? So let's take a 5-minute break. We'll come back and the last half hour is going to be open review anything you guys are wondering about. We can go over the answers to the tests if you'd like, whatever y'all want to do. So let's take a 5-minute break. Y'all, great attention, great discussion surrounding epinephrine, and we'll come back at 8:30 and finish out. Hey, Patty. I wasn't sure how you wanted to do review, if you want to do like open questions or if you wanted to go over the tests, up to you. I mean,
what do we have?
Let me know.
Another 25 minutes?
Yeah.
Hopefully we never have to deal with a patron, as we call a guest, that presents with their tongue swollen. Those kind of people usually have EpiPens, and they never get that far, hopefully.
Yep.
It's not fun to watch.
Can you actually get an EpiPen over the counter, or it has to be prescription?
It has to be prescribed.
You can tell any
Something
doctor
that
allergic
they-
to bees.
Something that they need to have with them, pretty much.
Right? People that have reactions to food or substances, they usually have an EpiPen because they already know. And sometimes they have a bracelet that tells them that they're allergic to certain things. But we had one gentleman that we transported that his tongue was almost that big. We got him to the ER. It was bad. So are we back? Okay, as Greg said, do you want to go over what he discussed, what the two topics that he did? Anything that you want to talk about a little bit more? You feel comfortable with it?
Talk a lot about our scope in general. Kind of curious on, is there, or what is the defined scope exactly?
Well, we're protected under the NSP as long as you practice what you're taught under NSP protocols. You can't go any further than that because you're only OEC techs, first responders, and you're going to be working with people that are EMTs, EMTAs, paramedics, but we stay at one level. We do have a medical director, so we're trying to implement more things for us, especially for people that have a little bit more training. But right now we stay at a level of OEC.
I guess which is what exactly? Like, is there
No medicine.
Go ahead.
O2 and
Yeah.
transport.
right? That's kind of what I mean.
Yep.
Well,
Stick to the basics.
you're learning everything, how to recognize, how to treat anything that is severe enough. You need to get them off the mountain. So what you're doing is you're basically treating them to the point where you can maintain until someone comes to pick them up. If they need ALS and they need flight, if they can go by car with their friend. But I mean, if someone has a fractured shoulder, dislocated shoulder, let's say, you're going to run into someone that says, hey, I don't want an ambulance. I can't afford it. You can recommend it. You can call. But if they don't want to go, they can cancel it. They have that right. So that's why you have to make sure they sign an AMA, which is against medical advice, which is yours, to cover yourself and the mountain itself. You can only recommend, but when someone has an MI, hopefully you'll recognize that, you'll treat it. but in the process, you'll initiate flight. You'll talk to management. You'll give your report, what you have. Management decides. They'll either initiate flight. Sometimes it only takes 20 minutes, and they'll initiate ground transport, which sometimes can take 45 minutes. So what you want to do is basically give the best you can for what you have to get that patient off the mountain and into a facility that can help them. And yes, you're going to splint, isolate, treat, transport. Does that make sense?
Yeah.
And I would add that taking someone badly injured down the mountain is not trivial to start with.
No, you want to get them off the slope for one thing. You want to get someone off the slope in the aid room where you can treat a little bit more. But in the process of treating, you've already initiated transport. So all you can do is try to make that patient comfortable as much as possible. If they need O2, you're going to give them O2. If you need a splint, you're going to do a splint. You need to ice, you're going to ice. You're going to do whatever is in your scope of practice. Also, there is insurance that you can carry. It's called EMS insurance. It's not that expensive for yourself, but you're protected both ways as long as you don't go above, or let's say out of your scope of practice. There are certain things you can do, certain things that you can't do. Just like Greg said, hopefully you don't see a patient that is so severe that it looks like they're going to die right there without an epi. But most people carry EpiPens that have that problem.
Page 11 in our book discusses a lot of the ins and outs of the Good Samaritan law and how OEC is related to or in effect covered or what isn't.
Right.
Greg, also for scope, did you get the outdoor emergency care book?
I ordered it like 2 days ago, I think.
Okay, sure.
Monday was the first class I was in, so.
Sure. No, I'm not trying to rush you. It's just whatever's in that book is in your scope. That's the OEC scope. So like any procedures that are taught in the book are procedures that we would do on the mountain would be in our scope. If it's not in the book, just assume it's out of your scope. So like there's no medication in the book that's out of our scope. There's no advanced airways in the book that's out of our scope. If it's in the book, it's in our scope. That's like the best description of our scope I could give.
Okay.
Any other questions, concerns?
Yeah, back to the pulse ox.
Okay.
I know you said we're not going to treat based on the numbers, but can we use those numbers to determine, like, if we give them oxygen, we expect those numbers to go up? Or is it just, if we give them oxygen, those numbers are going to automatically go up, so it's not even worth it looking at them?
Yeah, no, I shouldn't have said, or I didn't mean to imply you don't use the number at all. I just was trying to say that you don't let the number trump like a clinical presentation. So like, if the number says they're at 96, but they're struggling to breathe, then you don't trust the number. But what you're saying about using, like, if you want to check their vitals every 5 minutes and monitor their oxygen saturation and look for a trend that is upward or that doesn't improve or that even goes downward, yeah, that's a great thing to add to, of course, yeah. No, I didn't mean to suggest it's like a worthless metric. I just wouldn't want you to focus too much on it and then miss the actual.
Yeah, don't treat based on it. Treat based on the patient. But if we give them oxygen and that number's still dropping, then we got a problem.
Yeah, absolutely. No, it can be a good thing to look at to add some color.
And it's good to tell them that we gave them oxygen and it's up to this number now, so makes it look good.
It shows you're monitoring your intervention. Yep.
Also, if the patient is having trouble breathing and you put a nasal cannula on them and it's not doing anything, maybe you should change from a nasal cannula to a non-rebreather. So that's why you always pay attention. Anything else? Nothing. How about the test? No questions, concerns?
Okay, let's talk about next Wednesday.
Yeah.
Okay, so I've looked at,
Still thinking it.
okay, here I go. Here we go. I've looked at the syllabus. So if we don't do next Wednesday, then we have, next Wednesday is 2 hours, almost 3 hours. We could probably do it in 2 hours. But then we have, on Monday, principles of trauma, face and eye and neck. GI, reproductive, childbirth. You know what? I think you're trying to get out of childbirth. Is that true?
I'm thinking the chances are pretty low that I'm going to need that up there.
Well, that's what you think.
They're not zero.
True. True. Well, you're on the way up and back, maybe more, but
Yeah. Okay.
at the lodge, there's no telling.
So why don't we see what happens on Monday? And maybe we can jump into a part of it on Monday, like the GI, the gyno, and the reproductive, a little bit of that. And then we may be able to suppress that and go to the following Monday. How's that sound?
Play it by ear. Sounds good.
Okay.
Good.
So I'm going to send you the test for those chapters and see how well you did. That means you would have to read those chapters. So that's all I have, really. So then our next meeting is Monday, and cardiovascular emergencies. Greg, are you available or you want to pass?
I can do it if you don't have someone else who wants to teach it, sure.
So far I don't.
Oh, actually, wait. No, I can't. I'm sorry. I'm switching to nights next week, and my night shift starts at 6 p.m. So I won't be able to next week.
All right. So we'll take care of that. But I thank you for doing what you're doing.
Yeah, of course. Happy to.
Okay, so I guess that's it. Anything else from anyone else?
I don't know if I'm going to be here. Definitely on Monday. I'm traveling medical, so
Okay,
just FYI.
all right. Let me think what else. Did everyone sign in for the evening? If you didn't, please do.
You have to sign in.
Yes,
Just write your name in the chat.
Oh,
please. I want to know who Moto is. G7 Power. Looks like that person's been driving. So I don't know. Okay, I'm going to say goodnight.
Thanks, y'all.
Thank you.
Yeah.
Thank you guys.
Good discussion tonight. Good job, everyone. Have a good night.
Thanks, you too. Thanks, Greg. Thanks, Patty.
Thank you.
Thanks, bye.
And Patty, I can come back. Let's see. I'm only working nights for a week, and then I'm going back to days the following week.
Okay, let me see.
I believe.
You have a schedule?
I do, but it's just weekly, basically. And they don't tell me what I'm going to do until I'm on that service, and then the service tells me. So it's kind of a loose schedule.
Okay.
But I know I'll be on nights next week. They told me that last week.
Are you looking forward to it?
Yeah, I mean, I think it's an interesting thing. It's like the pediatric inpatient at night, so deal with some issues.